Sit back, start.
We are going to start the program. I request everyone, delegates, postgraduates, kindly take your seats in the auditorium. Good morning, respected dignitaries, delegates, and postgraduates. This is Dr. Francis, Assistant Professor in the Department of Oral and Maxillofacial Surgery, St. Joseph Dental College.
And I'm Reshma Verghese, and we will be your hosts for today.
We welcome you all to this 13th AP Annual State Conference held at St. Joseph Dental College. The theme of this conference is Explore Beyond the Horizon. This conference was previously to be held in the last year, that is in 2020, but due to this pandemic situation, there is delay in hosting the conference. Under the normal circumstances, the conference would have been conducted for 2 days, but owing the current protocol, we have scheduled this conference for a single day. And also observing the safety precautions, the presentations of the postgraduate students is being held in online, and the presentations of our respected speakers is being held at the venue.
Without further ado, let's officially begin the event. We request the dignitaries to please take their seats onto the dais. At first, we welcome Reverend Father Moses Garu, Secretary and Correspondent, St. Joseph Dental College, onto the dais, please.
Let's welcome him with applause, please. Thank you, Father. Now we welcome Reverend Father Bala Garu, Vicar General of VDMC Trust, onto the dais. We welcome you, Father. He is a former Secretary and Correspondent of St. Joseph Dental College.
Thank you, Father. May I now request Dr. N. Slivaraju Garu, Principal, St. Joseph Dental College, onto the dais, please.
Thank you, sir. We welcome the organizing chairman, Dr. S. Raviraj Kumar sir, professor and head of the department in oral and maxillofacial surgery, St. Joseph.
Thank you, sir. We welcome the organizing secretary, Dr. Vamsi Krishna Reddy, professor of the Department of Oral and Maxillofacial Surgery. Sir, please.
We welcome the scientific chairman, Dr. Srikanth, reader in the oral and maxillofacial surgery, onto the dais, please.
Thank you, sir. We welcome Dr. Raj Subhash Garu, AP State President, AOMSI.
Thank you, sir. We welcome Dr. UVR Chaudhary Garu, AP State Secretary of AOMSI.
Thank you, sir. To begin this auspicious occasion, may I now request Dr. Nisi and Dr. Sagarika to invoke the presence of the Lord Almighty with a prayer song. May I now request all of you to kindly rise for the invocation.
Jesus, I believe in you. Jesus, I belong to you. You're the reason that I live, the reason that I sing, and all I
Thank you, Nissi and Sagarika. Now we will have our traditional auspicious lamp lighting ceremony as a tribute to the Lord. I request our honorable dignitaries on the dais to please proceed forward for the lamp lighting.
Thanks a lot to all the luminaries. Now may I request Principal Dr. N. Slivaraju, sir, to kindly address the gathering. Please, sir.
Good morning, one and all. Dignitaries on the dais, off the dais, dear participants, I would like to welcome you all for this 13th AOMSI AP Chapter Conference, which is held at St. Joseph Dental College. For this, I would like to welcome our Secretary and Correspondent, Father Moses. Father, welcome you, Father. I also would like to welcome our Founder Secretary and Vicar General of Diocese of Elur, Father Balagaru, for this occasion. Welcome you, Father. I welcome the President of AOMSI AP Chapter, Dr. Raj Subhash. Welcome you, sir. I also welcome the Secretary, Dr. U.V. Chowdhury. Welcome you, sir. I would also like to welcome our own HOD, Dr. Raviraj Kumar. I welcome you, sir. And I also welcome Dr. Vamsi, Dr. Srikanth for this August gathering. I also would like to welcome all the HODs, the principals from various dental colleges, the PG students from various dental colleges, the practitioners from various cities, the guest speakers from various states. Sir, welcome you all for this August gathering. Before I conclude, I would like to say a story. Few friends, before I start this, I want to say one thing to everybody. Maybe this conference or this lecture may not be important for me, but the person sitting next to me, he might catch up few points out of this. So we don't have any right to disturb anybody sitting next to us. Please allow them to listen. So the story what I'm saying is, please listen carefully. Once 4 friends, they go on a tour to one jungle, forest. Their plan to come back the day evening. But unfortunately, they lost their way. They need to spend 2 nights in that forest. So as usual, somebody who is very lazy, somebody is thinking that anyway I cannot do anything, doing nothing other than just maybe sleeping, not doing any other work. But there are 1 or 2 persons out of that, whatever they can try it, they are trying it. Whatever they can pick up from there, they are trying to pick up. Once they found the way, then they started memorizing what they got from those 2 nights. Some people really, they got some diamonds out of that, whatever they picked up there. Maybe some waste material is there, and there are some diamonds also. So out of this, what I want to say, maybe today's conference, whatever you are listening from the speakers, all the points what they are saying, it may not be useful to you in life. But there are some important points out of that. So try to pick that important points. They are like your diamonds. When I'm in UZ, I think many of you know Dr. Bhaskar Rao sir. When I'm trying to do a removal of one broken root apex, he came and asked me, what you're doing? Sir, trying to remove one broken apex. He just took one probe and he had put in the root canal area. He just took out, not even 5 seconds. That is one point that I learned it, but before learning that point, remember, if you are not using it judiciously, you are forcing that root apex into maxillary sinus or into the mandibular canal also. So try to pick up the points carefully and try to use judiciously. So out of all the lectures today that's happening, I'm sure that you will definitely pick up some important points. So I wish you all a success conference and a happy stay here. Thank you all.
Thank you very much, sir, for your valuable words. Now I request our correspondent and secretary, Reverend Father Moses Garam, to address this gathering.
Honorable dignitaries, respected doctors, dear students and friends, good morning to all of you. It gives me immense pleasure and honor to extend a warm welcome to you all for the August gathering in the capacity of Secretary and correspondent of our prestigious institution, St. Joseph's Dental College, on the eve of 13th AP State Association of Oral and Maxillofacial Surgeons of India. I must congratulate the Department of Oral and Maxillofacial Surgery in organizing the conference in a fitting manner. It is a highly specialized branch of study that addresses variety of dental and facial deformities and diseases. Our St. Joseph Dental College is the vision and the brainchild of His Excellency, Most Reverend John Mulagada, the pioneer bishop of Eluru. His vision took a shape and reality under the aegis of the founding secretary and correspondent Reverend Father Bala in the year 2002. He is the present Vicar General of Eluru Diocese, representing the chairman and the bishop. Ever since His Excellency Most Reverend J.R. Pulumera took reins of the chairman of our college, it has been striding the paths of development. If God wills, we will be striving to achieve more desired goals in future. The chairman extends his greetings to all of us. I am very proud to announce that ours is the only dental college fully equipped with the possible maximum infrastructure managed by the Catholic Diocese all over India. I am glad to announce you that as the part of the students and staff exchange program, we are collaborating with the overseas universities. Some of them are Tufts University School of Dental Medicine, Boston, USA, University of Pacific, Arthur Dugono School of Dentistry, San Francisco, USA, University of British Columbia, Canada, and Dentistry of Chieti, Italy, and also we have the tie-up with the University of Torino. In conclusion, I thank each and everyone who have put their efforts in making this conference a grand success. Wish you a pleasant stay in St. Joseph's Dental Campus. Thank you and God bless.
Thanks a lot, Father. Now may I take the honor to request Dr. Vamsi Reddy, Sir, Professor of the Department of Oral and Maxillofacial Surgery, to address the gathering. Sir, please.
Good morning to everyone. I take this privilege as Organizing Secretary to welcome you, AP AOMSI, 13th AP AOMSI Chapter Conference at St. Joseph Dental College. 5 decades ago, 6 great minds came together with a common goal to have a separate organization in oral surgery in our country. Thus, in 1969, Association of Oral Surgeons, AOSI, was found. Later in 1977, at Sydney Conference, AOSI got affiliated with International Association of Oral Surgery. In 1985, AOSI was renamed as AOMSI, has grown into the leaps and bounds with 50 years of hard work and perseverance. The first AP AOMSI chapter was started in 2008 and has been successfully carried out each year. In this day, the postgraduates have a burning desire to pursue various advances and super specialization like onco, microvascular reconstructive surgery, craniofacial surgery, and implantology as well. This conference is aimed to ignite the young minds and show them a pathway to pursue various advances after post-graduation. Most importantly, I want to acknowledge and wholeheartedly thank the eminent speakers who have made the great effort with us to, despite the difficulties in the current pandemic situation, and make this conference as greatly enriching the experience. Thank you.
Thank you, sir. Now I request the Vicar General of VDMC Trust, Reverend Father Bala Garu, to address this gathering.
Good morning, everybody. I deem it a privilege and also a pleasure to be here this morning to address at the inaugural ceremony of the AOSMI annual state conference. And I wish the host, Dr. Raviraja, HOD, OMFS SJDC, all the best for this annual conference. I'm sure under his able guidance, this conference will be a great success. And today I'm very happy to have met Professor Thangavelu from Chennai, sir. Chennai. Sir, hearty welcome to you. We are glad to have you here. And I also recognize the presence of my old friend, Professor, HOD, Principal, Chairman of Sibar Dental College, Dr. LKP. Sir, happy to have you here. I'm also happy to see many of our own alumni becoming faculty members in other colleges. Very happy to have met you, my friends. Welcome back to SJDC. And I also give you wishes and greetings in the name of the chairman, Bishop Jairao Pulimera. For another important occasion, he is away in Warangal. He asked me to represent him at this meeting and greet all of you and extend God's blessings on this annual state conference. Thank you very much and God bless you all.
Thanks a lot, Father. May I now take the honor to request Dr. Raviraj Kumar, sir, Professor and Head of the Department of Oral and Maxillofacial Surgery, to kindly address the gathering. Sir, please.
A very good morning to the respected dignitaries on the dais and off the dais. Welcome to the senior most faculty, my professor, my mentor and guru, Dr. Thangavelu sir, Dr. Gosla Srinivas sir, and Dr. LKP sir, and all the maxillofacial fraternity from the various colleges in and around Andhra. It gives me immense pleasure to welcome you all to this 13th AP State AOMSI Annual Conference. With the able guidance of the association and some of the colleagues, I could able to conduct this within a short notice because the conference is always held for 2 days, the state conference, because of the pandemic and limited facilities or the restrictions. We have taken permission in the EC of state conference and conducting it for a day where the scientific schedule is only by the delegate speakers. The routine post-graduation papers are already done, which will be briefed by Dr. Srikanth, what are the number of papers received and what are the number of registrations. Also the theme Explore Beyond the Horizon was selected to make the postgraduates and the young maxillofacial surgeons to know what are the diversified options that are available post-MDS course. Keeping the theme into the mind, we have selected the topics like microvascular surgery, pterygoid implants, hair transplantation, cleft lip and palate and craniofacial anomalies. Because these days we have found most of the postgraduates, in fact the postgraduates from the St. Joseph Dental College who have finished with the previous batches, I saw them extending their limits and practicing and into the various fields like cleft lip and palate, hair transplantation, like that. So the theme aptly suited for this particular conference. I'm thankful to the seniors and my dear colleagues for their timely suggestions and inputs. If anything falls short with this single day conference, I request all of you to take it lightly and bring it to my notice. I hope you'll have a good scientific session and enjoy the session. Thank you.
Thank you, sir. Thank you for your welcoming note. Now I request the scientific chairman, Dr. Srikanth sir, to address the gathering.
Very good morning to all. I, Dr. Srikanth, Scientific Chairman of 13th AOMSI State Chapter, announce the registrations enrolled for the various scientific presentations. We had a total of 43 free scientific paper registrations, and for the prize paper category, 10 members from AP State and 13 under the non-AP State category. And for a free poster, a total of 40 candidates enrolled, and for the prize poster category, 6 members enrolled from AP State and 8 for the non-AP category. Thank you.
Thanks a lot, Dr. Srikanth, sir. Now may I request Dr. UVR Chowdhury, sir, AP State Secretary, AOMSI, to address the gathering. Sir, please.
A very good morning to all the dignitaries on the stage and off the stage. On behalf of AP AOMSI, I welcome you all for the 13th AP AOMSI annual conference. I request all the PGs and delegates to please follow the COVID protocols. And as we all know, what had happened to the last 2 years, this pandemic has made us sit at the corner of the life. And I thank the management of St. Joseph's Dental College and the organizing committee for giving us an opportunity to meet again after a long time. And I wish all the very best for the organizing committee to make this event a grand success. Thank you.
Thank you, sir, for your words. Now I request Dr. Raj Shubha, sir, AP State President of AOMSI, to address the gathering. Thank you, sir.
Good morning, one and all. To my seniors, my mentors, who are all gathered here, and the dignitaries on the dais. I thank you, one and all. As a AP State President, I welcome one and all for 13th annual conference. I hope you will enjoy and you will get good knowledge. I especially thanks to Bala sir and Moses sir for in this critical crisis situations. They gave us good opportunity to learn. I once again thank you to both of you, and I also very much thankful to my sir. I don't call him with the name, my principal of St. Joseph. On the dais, I always say, call him my principal of St. Joseph. Sir, I thank you very much providing such a beautiful gathering. And I once again thanks to my AP AOMSI executive team, especially UVR. We don't know anything what is happening, but he knows everything in the committee, what to do, what not to do. And all. So as a namesake, I am a president, but everything is run by Dr. UVR Chaudhary. We should thanks to UVR Chaudhary to conducting such a great conference. Thank you, UVR. And I also welcome our, I can't say other state, it is my brother's state, Telangana state. They all came, and I also thanks to Tangavelu sir, my mentor. Thank you, one and all. Enjoy this evening.
Thank you, sir. Thank you very much.
Now I request the dignitaries to occupy the seats of the dais. So the scientific session will start soon. Before actually starting the scientific session, we have wishes from the national presidents of AOMSI, Dr. Veerababu sir, and our Honorable Secretary, Dr. Preetham Shetty. They have sent a video by wishing the conference all the success. It's just going to be played now, and later the scientific session will commence.
Students and friends, I take great pleasure in inviting you all for this annual Andhra State Conference, which is the 13th conference. They have taken enormous effect in conducting this two-day physical conference, I congratulate the state office bearers as well as the organizing committee members. I am going to explore beyond the horizon of the OMFS. I wish the conference a grand success. Please don't let your guard down. Stay safe. Enjoy the conference. Jai Hind.
That's the message by AOMSI National President Dr. Veer Bahu, sir.
I'd like to congratulate AP Andhra State Chapter for Chapter Conference. It's nice to see that all of you are going to meet each other. I'm extremely sorry I can't be there in person. However, I'm hoping to see you all at Mangalore. Let's all meet at Mangalore for the Mangalore Conference. Let's make Mangalore Conference a big success. Wish you all the best for the conference. Thank you.
We shall now commence the scientific session. I request Dr. Praveen, reader in the Department of Oral and Maxillofacial Surgery, to introduce our first speaker, Dr. Anant Nag, sir.
Good morning to one and all. I take the privilege of welcoming Dr. Anant Nag Jakula, sir, to give the keynote lecture. Dr. Anant Nag, sir, completed his post-graduation from Savita Dental College, Chennai. He has 20 years of experience in teaching and has worked in prestigious institutions such as Lenora Dental College and St. Joseph Dental College. Currently, sir is working as a professor and head of the department in GSL Dental College, Rajahmundry. Dr. Anant, sir, specializes in temporomandibular joint surgeries, craniofacial anomaly surgeries, orthognathic surgeries, head and neck oncology, and microvascular surgeries. Sir is also a diploma holder in International Congress of Oral Implantologists and has keen interest in TMJ arthroscopy and styloendoscopy. He was also the organizing chairman at the 9th Annual State Specialty Conference in 2016 at Rajahmundry. Sir, it is our privilege to welcome you to this prestigious conference at St. Joseph Dental College as a keynote speaker. Thank you, sir.
Now we welcome Anant Nag, sir, for the scientific session.
Hello. 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 Okay. Banan, the clarity. Clarity is good. Okay, fine. Okay. I thank Dr. Praveen for introducing me. Louder. Okay, okay. Good morning, everyone. Nice to have a live conference instead of streaming after 2 years. This venue, St. Joseph, is special to me. I started my academic career here. So I had a pleasure working with all these surgeons. I thank each and every one of this sharing knowledge among us. So coming to my lecture, microvascular reconstruction, the current trend to reconstruct and rehabilitate. I'd say that it is a perfect way of reconstructing and rehabilitating. And it is also free tissue transfer. You can transfer the tissue from one part of the body to other with this microvascular reconstruction. So I tell that this is a need of the hour because we all should be practicing this to give a better life for the post-onco patients. So coming to the incidence, almost 6 lakhs people suffer from head and neck cancers. And out of that, around 3 lakhs deaths are there. Remaining other 3 lakhs, we have to definitely give a better life for them. And the only way to give a better life is microvascular reconstruction. My presentation is just, I'm a starter of microvascular surgeries. This is my little experience I am sharing with you all. We started our head and neck onco surgeries from 2019 November. So we have done 120 cases. And out of 120 cases, we have done 31 free flaps. Out of that, radial forearm flap, 18 we have done, fibula 10, and anterolateral thigh, 3 we have done. So coming to the basics of the reconstruction, so we divided it into the soft tissue and hard tissue. In hard tissue, basics is skin grafting and local advancement of the local tissues and local flaps, and the distant flaps and microvascular surgery is the ultimate recon procedure. Coming to the hard tissues, again, simple way of reconstructing or replacing the hard tissues is a recon plate. And next method is, along with the recon plate, non-vascular bone grafting, and ultimate replacement of lost bone is a microvascular reconstruction with free fibula. So coming to the skin grafting, this is a case of carcinoma of buccal mucosa. This is a lesion we are seeing. This is the marking of the lesion. This is the excision of the lesion. And depth of the lesion is not too much. So external skin and subcutaneous tissue is spared. So we thought to reconstruct it with a simple skin grafting. And we have done a modified neck dissection for this case. And along with the skin grafting, it is important to place a bolus dressing both external and intraorally to prevent a hematoma beneath the skin graft, to prevent the necrosis of the graft. Last one is after the closure. So coming to the limitations, what limitations we can have when we are doing a skin grafting are donor site morbidity. Almost any flap we have a donor site morbidity. Necrosis of the graft of skin grafting is the most commonly we see. So this is a basal cell carcinoma just inferior to the medial canthus of the eye. So local excision was done, and wedge-shaped resection of the lesion is done, and local advancement of the flaps are done. This is a varicose carcinoma of the corner of the mouth. This lesion extended from the intraoral to the extraoral. So there is a complete defect of the corner of the mouth. So what we have done is we have used inferiorly based nasolabial flap. So only disadvantage or limitations in this flap is excess stretching of the skin and at the suture line and excess facial scarring. So coming to the next is DP flap. This is a case of carcinoma of left cheek. excision of the skin. This is the excised site, and deltoperoral flap insertion. So limitations again, donor site morbidity, and secondary surgery we have to perform to detach the flap. So these are the disadvantages of deltopectoral flap. This is the PMMC flap. This is a case of this is a case of carcinoma of the floor of the mouth involving the mandible. Segmental osteotomy was done along with the modified neck dissection. This is the markings of the PMMC flap. So flap rising, flap path, and flap insertion. So the floor of the mouth closure with PMMC flap, this is the final closure. So donor side morbidity, as I told, for every flaps we have that, and non-flexibility of the neck due to the passage of flap through the neck. So this is the case. This week only we have done, this Tuesday I have done this case. Extensive squamous cell carcinoma of the left buccal mucosa involving the mandible, posterior part of the maxilla, and most of the part of the skin extraorally it is involved. So wide excision is planned, bite resection is done, hemimandibulectomy done, posterior maxillectomy done, along with the supramohyoid. I don't say supramohyoid, it's a radical neck dissection, functional modified radical neck dissection was done. So actually I planned for only bipedal PMMC flap, but after the excision site I thought it's a huge lesion. I have to reconstruct from the posterior part of the maxilla to the extraoral skin loss. So definitely I thought it's difficult with the PMMC. So I have taken another flap which is DP also. So this is the final result of the case. So coming to the basics of bony reconstruction, this case we reconstructed with just a reconstruction plate. This is a giant hematoblastoma. Recently one of my PG got a first prize regarding this presentation. This huge lesion. Whenever we see this much of huge lesion, actually our oncosurgeon, he asked me how we can do this. He thought a lot of reconstruction has to be done. I told it's simple, because we have a lot of expanded skin and a lot of expanded mucosa that helps us to have a primary closure. That is my idea of this surgery. So this is the incision making, entire tromere exposure, ramus to ramus resection was done. So this is the excision site, and angle to angle plate is placed. This is the final outcome of the post OPG. So when we do only recon plate replacement, we might have a chances of plate exposure or plate fracture. So this is the final result of the case. Patient is happy. She is showing thumbs up to us, she is smiling, but we are not happy because we can't rehabilitate her dentition. So what is the solution? Ultimately we have to go for microvascular recon. This is the next stage of reconstruction, which is where recon plate is placed and non-vascular grafts are given. So this is a left side ameloblastoma case. So after excision, recon plate is placed. This is the total specimen. Hemimandibulectomy was done. So iliac bone grafting was taken. So non-vascular bone graft is fixed. So this is the post OPG. So we have again limitations in this type of reconstruction. Non-vascular, this is non-vascular, chances of resorption and infection, sometimes no bone formation. Again, plate itself will be left alone and there might be chances of plate exposure and fracture. So these are all the basic methods of reconstruction of soft tissues and hard tissues. Ultimately, we have to start doing these microvascular surgeries. The reconstruction and the rehabilitation will be the perfect way of replacement. So what is a microvascular surgery? It's just detaching the venous and blood supply from the donor site and connecting to the blood vessels, that is arteries and veins in the receptor site. So what we can do in a head and neck area, we can reconstruct maxilla, we can reconstruct mandible, we can reconstruct a tongue, we can reconstruct floor of the mouth, mucosa, buccal mucosa, lips, everything. So in our experience, we have done majorly of 3 kinds of microvascular reconstruction. One is radial forearm free flap, one is fibula, and last one is anterolateral thigh flap. So coming to the radial forearm flap, we are going to discuss basically a conventional type of radial forearm flap and shape modified radial forearm flap in this presentation. So coming to the superficial anatomy, what we have to look at first is a radial artery, cephalic vein, or we call it as a superficial cutaneous vein. And along with the radial vein, we have to check for the vena commitans. And musculature, muscles and tendons, brachioradialis muscle and flexor carpi radialis and palmaris longus. And pedicle length up to the just below the antecubital fossa, where it originates from the brachial artery. So coming to the anatomical considerations, what we can get from this flap: skin, fascia. Optional tissues, we can get a tendon and bone. Blood supply, basically radial artery. Veins, vena commitans. Vena commitans, if we don't have a cephalic vein, prominent cephalic vein, then we can go for vena commitans. If you have a cephalic vein, that we have to give a first preference to the only cephalic vein. Nerves to look for: medial and lateral radial nerves. Pedicle length up to the branching, up to just below the antecubital fossa, we can increase our pedicle length. So coming to the prerequisites. So what we have to do before doing the radial forearm flap? One is definitely we have to check for arteriovenous Doppler. So that gives the patency of the vessels. So whenever you take a flap, you need a patency of the vessels. So radial and cephalic veins, venous and arterial patency, we should look for atherosclerotic lesions. So handheld Doppler, which helps to locate this is a handheld Doppler, which helps to locate the perforators of the skin flap. And one of the important tests we do in a radial forearm flap is the Allen's test. Allen's test is nothing but what we do is we compress both the ulnar and radial arteries for a few seconds. We allow the palm to become pale. We release it. Within 5 seconds, there should be a perfusion. That gives a positive indication that the patency of the radial vessels and the ulnar artery are good, so that we can proceed for the radial forearm free flap. So first we will be talking about the conventional type. Conventional, this is the case of posterior maxilla. Always maxillary reconstruction is difficult. This case only we have done a soft tissue reconstruction. We didn't do a hard tissue reconstruction. So, sorry. This is the lesion. This is the marking of the lesion. This is the total excision of the lesion. So we have done a bilateral functional dissection, modified neck dissection. So these are the markings of the radial forearm flap. This is the radial artery. This is the cephalic vein. This is the skin pedal, what we have taken, size of the skin pedal. After elevating the skin pedal, one longitudinal incision is placed and entire pedicule of the radial artery and the cephalic vein is dissected. So this is the entire flap elevation before its detachment. This is after detachment of the flap. This is the site of the donor. So insertion of the flap, this is the anastomosis site. Most commonly we use common facial vein in head and neck and facial artery. Those are the ideal arteries and veins for the anastomosis. This is the closure. 1 year post-op, excellent healing of the defect site. So this is one of the extensive radial forearm flap. Again, this case, extensive resection, bite resection was done, posterior mandible, maxilla is removed, hemimandibulectomy is done. So extraoral skin loss is there. So this is a total defect. Extensive radial forearm flap is marked. So flap in elevation, suppression and the donor site. So in this case, what difficulty we have faced is flap insertion. Definitely the flap coverage should start from the intraoral, from the most superior and posterior part of the oral cavity. It has to turn outside and cover the skin defect on the face. This is 15-day post-op healing. Conventional radial forearm free flap. This is to reconstruct squamous cell carcinoma of the lateral border of the tongue. So this is a lesion excised site. Modified neck dissection was done. This is the flap design, flap elevation, flap separation, anastomosis site and closure of the donor site. So this is a flap insertion and closure. 6 months post-op. You can see the healthy flap reconstruction on the right side of the tongue. So shape modified. What is shape modified? What are these advantages compared to the conventional radial forearm flap? Primary closure, we can get excellent post-operative healing, less neurological defects and less scarring. So mainly difference between conventional and shape modified is you measure the width of the defect. So you double that width and you take a full length flap. So this is a lesion. We select shape modified for smaller lesions only, not bigger lesions. So this is a very small lesion on the tongue. So again, modified radical neck was done. You can see the length of the flap is more than the width. So what we do is we fold the length of the flap. Medial part of the flap, we do the suturing, make it as a defect size and we insert the flap at the defect site. So you can see the insertion. This is the post-op review. 6 months post-op. So coming to the free fibula. Free fibula, again we will be going to discuss about the conventional and 3-dimensional template assisted free fibula flap. So coming to the superficial anatomy, again, skin, subcutaneous tissue, intramuscular septum, psoarious muscle and peroneal muscle, periosteum of the fibula, fibula bone and interseptal intraosseous septum. Below that, posterior tibialis muscle. Whenever you dissect the posterior tibialis muscle, we see the peroneal artery, which is the main pedicule with vena comitans, and dissection of FDL and FHL muscles. This is the markings of the fibula. Lower is lateral malleolar projection process and upper is the fibula head. So we leave around 2 inches of bone either side and we mark the skin pedal. Those are the markings of the fibula. So coming to the anatomical consideration, again what we can get from this flap is bone with adjacent periosteum, soft tissues, and it can be with the skin or without the skin. Again blood supply, peroneal artery, and veins as vena comitans, and nerves to look for is a posterior tibial nerve. And pedicle length, sometimes we can get a short one. If you want a longer one, you have to dissect more proximal to the fibula. Just check. Okay, sorry. Okay, this is the first case about fibula, free fibula. This is a carcinoma of the anterior floor of the mouth with anterior mandible is involved. So anterior segmental resection was done. So difficult to reconstruct this is to get the arch form. So it is a central arch reconstruction. So the difficulty is to insertion of the fibula bone. So this is the excised site, reconstruction plate is placed. These are the fibula markings, fibula bone is excised and the measurements was done. So subperiosteal osteotomy is done to attain an arch form of the central arch reconstruction of the mandible. And this is the incision and this is the anastomosis site. Okay. So this is the final result of the patient after 1 year post-op. So this is a 3-dimensional. I'll just go fast because less time is there. 3-dimensional, what we do in the 3-dimensional compared to the conventional is, we just do a 3D printing of the mandible, we do a mock surgery, we 3D print the lower border of the lower border splint also, even plate adaptation we do pre-operatively. So again, neck dissection is done, and this is the main thing we do before, after resection, lower border 3D splint is fixed and plate is fixed. After plate is fixed, we remove the lower supporting 3D printed splint. So fibula bone is excised, inserted. This is the final result. So anterolateral, last one is anterolateral thigh flap. We have only conventional in this. So coming to the markings, anterior superior iliac spine and superior lateral patella, and midpoint is the perforator. Around that perforator we elevate the flap. So coming to the superficial anatomy, skin, subcutaneous tissue, fascia, and muscles, rectus femoris muscle and versus lateralis. In between the muscles, these muscles, our pedicle will be running. The pedicle is lateral descending branch of lateral deep circumflex femoral artery, and it's vena comitans. And coming to the anatomical concentration, skin, fat, and fascia. Advantages of this flap is a huge flap we can get, 18 to 22 centimeters. So blood supply is, I already told you, it is a descending branch of lateral femoral circumflex artery, vena comitans. Nerves to look for is lateral femoral cutaneous nerve, and pedicle length is up to 7 centimeters or longer. So this is a case of carcinoma of maxilla involving the external skin. So there is after doing a total maxillectomy, we have left with a huge defect. So we actually planned for a radial forearm free flap, but we thought that won't be sufficient. So again, on table decision, we shifted to anterolateral thigh flap. Again, neck dissection is done on bilateral. So flap markings is done, flap elevation, flap trimming. Again, this is the anastomosis site. Flap insertion, I faced a lot of difficulty in inserting a huge flap because the thickness of the flap will be too much. So inserting is a big headache. That is the basic difficulty we have faced in this flap. So coming to the basics of microvascular, what we do. So how do you anastomosis? The type of anastomosis what we have is end-to-end, side-to-end and side-to-side. End-to-end and side-to-sides are related to the head and neck anastomosis. And how do you suture it? We have an 8 suture technique, which is first suture is placed here, second suture is placed here, then it is stretched, third suture is placed here, fourth is placed, fifth is placed. We flip off the other side of the vessel where the double clamps are placed. So again we do a 6th suture here, 7th and 8th. That finishes the anastomosis. So what are the steps? So steps what we have is identifying anastomosis vessels at the recipient site. So commonly we use facial artery and common facial vein. So perfect isolation and clipping with 100 and 200 clips. Next is placement of single clamp and trimming of the, freshening the vessel walls, that is a trimming of the tunica adventitia is done. So next is, this is important step, we do a continuous irrigation with a heparin 10,000 units in 100 ml to dilate the vessels and to prevent the blood clots. So single clamp placement is done. So after double clamp placement, final anastomosis is done with the 8-0 ethylene suture. So after anastomosis, we release all the clamps and check for the perfusion. So this is the video what you are seeing is basically after the releasing, after the anastomosis, after the releasing of the clamps, we have to see the pulsations in the flap. That is the basic initial checkup we do after the anastomosis. So another, after insertion of the flap, we check skin perfusion, skin pedal perfusion with just scraping of the skin with IM needle. So just you scrape the skin, wait, check for the perfusion. Instrumentation, what do you need? So this is the loops. I have both 3.5 and 5.5 I use depending upon the usage. And this is the handheld Doppler to check the perforators of the skin. And microvascular instrumentation, this is 100 and 200 clip holders or applicators. These are the double clamps and single clamps, micro scissors, micro needle holder, Jewel's forceps and micro forceps. And also we need a tourniquet. So fibula and radial forearm, we need a tourniquet to initiate the surgical process for the bloodless field. So when successes doesn't teach us anything, failures are the things which teach us. So what are all the failures we have faced and what are all the corrections we have done, I'll just finish them fast. So this is the case of carcinoma of the mandible where resection is done, floor reconstruction is done with the radial freearm for flap. So there was a necrosis. After that we did a PMMC also, that also got necrosis. So we left it for the secondary granulation. So why we face this problem? Because we used a venous anastomosis for EJV instead of using for a common facial vein. Because EJV is a superficial vein, it is always prone to the thermal injuries and traction injuries. So more chances of thrombi formation will be there in this kind of anastomosis. So never go for superficial vessel and anastomosis. Better go for the deep vessels. So next complication what we faced is the carcinoma of the tongue. We reconstructed with the radial forearm free flap. So what mistake we have done is, along with the reconstruction of the tongue, we have want to correct the SMF also, submucous fibrosis for the limited mouth opening. So bilateral nasolabial flaps are taken. So never do this procedure. Whenever you are doing a microvascular surgery, stick to the microvascular surgery. Don't do other surgeries surrounding the microvascular surgeries. That might compromise the blood supply. Also excess edema might compress the blood flow. So this is the problem what we faced here. Free fibula. Actually, this is the first case we did a free fibula for the reconstruction. Young female, around 18 years female, we have done mucoepidermal carcinoma of the mandible. So after, generally, immediately after the surgery, we didn't find any complications. But after 8 months, suddenly skin pedal was disappeared. Inside skin pedal was not there at all. Later, patient developed infection, plate infection and plate exposure. So when we reoperated again and checked, we found that fibula bone is necrosed. So causes, even I don't know. Any expertise can tell us what is the problem in this. So complication to ALT flap. This is a case where again mistakes were done. For CA allulus, we have done a marginal mandibulectomy instead of doing a segmental. So there was a recurrence. There was a huge recurrence. Again, we have taken an anterolateral thigh flap to we done an anterior segmental osteotomies and reconstruction with after this also, after the microvascular reconstruction also, patient developed a distance metastasis and ultimately we lost the patient. So coming to the keys to the success of this microvascular surgery, definitely perfect planning, good preoperative workups, surgical implementation of the flap, adequate postoperative care, long follow-up. This is the ultimate success of your microvascular surgery. You have to have a team. Team is very important for the success of the microvascular surgery. I have a beautiful team regarding this. This is our team. So our success is mainly on the team. So do the teamwork, because both the oncosurgery and the free flap has to be done consecutively. So because overloading of the GA drugs should not be there, and time lag from the flap elevation to the flap incision also, maximum you should take between half an hour to 1 hour, not more than that. So for young surgeons and upcoming PGs, this is my suggestion. Never limit yourself in your career. Explore beyond your limitations. There are so many procedures in OMFS surgery. So do everything, master everything and be success. This is my team. This is my anesthetician, Manju Garu, Dr. Manju. I proudly say that our department only does the tracheostomies. We do the tracheostomies. I have to thank him. He is a god to me. I learned from this institute only, onco and reconstruction. I teach from this institute only. So I am very thankful to Dr. Tarun Garu. Thank you.
Thank you, Dr. Anantnag sir, for the excellent presentation. Now there is an announcement from GSL Dental College on Onco program. Dr. Srikanth will brief you regarding this.
Good morning, one and all. I am Dr. Srikanth, Professor, Oral and Maxillofacial Surgery, GSL Dental College and Hospital. So we have heard Dr. Anantnag sir speaking about the cancer cases. I am a part of the team and we do the cancer surgeries here at the GSL Cancer Trust. We are now ready to announce that we are expanding the horizon and inviting all the postgraduates from all the colleges to attend their peripheral postings at our institute. Okay, this I am taking on behalf of our chairman, GSL Cancer Trust, Dr. Tarun Garu. He has asked us to inform that we are now ready to take up all the postgraduates for their peripheral postings. Second, can I have the next slide? Second, we are now in near future coming up with a fellowship program, that the senior residentship program for all the postgraduates who have completed and now become a masters after the postgraduate program. They can now, we are in near future starting up with this 1-year postgraduate fellowship program. Before that, I have a small announcement for the faculty. Before we commence this program, if any case is presented to the Department of Oral and Maxillofacial Surgery in your college, you can send a PG along with the patient to the GSL Cancer Trust, where he can attend the OTs, see the pre-op and post-op follow-up, and then can see the follow-up along with us. I thank you very much for the organizing committee for giving me this opportunity to introduce this small program. Thank you very much, one and all. I wish all of you a best of luck. Thank you.
Thank you, sir. Now, I call upon Soumya to introduce the next speaker of the scientific session.
Good morning, everyone. I, Dr. Soumya, take immense pleasure to introduce our next keynote speaker, Dr. Srikanth Gunturu. This task of introducing sir is indeed a great privilege. Dr. Srikanth sir graduated from KGF Dental College and Hospital, Karnataka. Sir did his MDS in Oral and Maxillofacial Surgery from AB Shetty Memorial Institute of Dental Sciences, Mangalore. Sir did his fellowship in Cleft and Craniofacial Surgery from Cleft Children International, NITTE, Meenakshi Institute of Craniofacial Surgery. Currently, sir is working as a professor at Dr. Sudha Nageshwar Rao Siddhartha Institute of Dental Sciences, Gannavaram. Sir has guided several valuable dissertations for postgraduates. Sir has several international and national publications and presented several papers and posters and guest lectures at various conferences. Dr. Srikanth sir is a hard-working, sincere, confident and self-motivated and an aggressive surgeon with a strong desire to perform and succeed. I now cordially invite Dr. Srikanth Gunturu sir to take over and deliver his valuable keynote lecture on the topic, Unraveling the Mysteries Beneath the Flap, Insights into the Prospects in Cleft Lip and Palate. Thank you, sir.
We welcome Srikanth sir onto the dais.
Like okay. A very good morning, and thank you for the introduction. I am Dr. Srikanth. I'm just here just to not to lecture anything on the techniques of the lip or anything. When I started my career back in 2014 from Vijayawada, initially I used to, so many people used to ask me whether there are so many cleft cases are there, or whether you can practice cleft lip and palate as your career. So trust me, there are so many needy people who require these surgeries. And so there are so many myths whether we can practice or whether we can continue our career as cleft and craniofacial surgeons. With this presentation, I'll tell you and I can show you that there are so many cases around Vijayawada and Gunturu also, and we have completed around approximately 120 cases in the last 7 years, and particularly 40 cases in the last 7 months. So actually, who can practice these cleft and craniofacial or cleft lip and palate surgeries? As we all know, we have evolved. Initially, we have evolved from most of the dentists have evolved are general dentists, general surgeons who have specialized into the diseases of the mouth and jaws. And they have emphasized the importance of the diseases of the mouth and jaws on the systemic conditions of the patient. So that is how we have evolved, and they used to be called as surgeon dentists in those days. And those who have not evolved from that thing, and those who used to just concentrate on the pain of the teeth, attending if the patient is having just the pain, attend the teeth. So those are not the professionals, but we are the professionals who used to address the patient systematically and who used to work with the patient. We have a formal education. We have a formal training of general medicine and general surgery also in our BDS curriculum. So essentially, an oral and maxillofacial surgeon is a trained who has adequately trained and who is also having an adequate knowledge of the dentistry. So that is what is the advantage advantage we are having when we are dealing with the diseases of the oral cavity. So we have the contributors over the centuries, right from the Hippocrates, who has who has contributed and who has developed the ways to reduce the dislocated mandible, to Simon P. Houlihan, who is the father of orthognathic surgery, and James Edmund Garrettson, who is the father of oral and maxillofacial surgery of the time, and who has used the dental engine for the first time in the oral and maxillofacial surgical procedures. So an ideal oral and maxillofacial surgeons, we should have a good knowledge of the general medicine and general surgery, and we should have an adequate knowledge of the dental techniques, and also we should have a special training in oral surgery. So this completes, this is essential actually. So any reconstruction in the oral cavity, any reconstructive techniques in the face have a foundation of the teeth. So if we have an adequate knowledge of the occlusion, definitely we are the better persons to reconstruct the face. So again, there is a dilemma whether we can do these complex procedures. Historically, there are few maxillofacial surgeons who are having the dual degree, and so we should have a thorough knowledge from the foundation to the specialization. And in India also, there are few surgeons like our Gosla sir, Dr. Vikram sir, and Krishnamurthy Punantaya sir, and Krishna Shamarao sir. They have done their dual degree, that they have done their MBBS also following their MDS degree, and they have they are quite successful, and they have give us a great path for us to go ahead in the field of oral and maxillofacial surgery. So as an essential thing, as an oral and maxillofacial surgeon, we should have these foundation skills, very important. And there are lots of debates in the international forums also, whether to just to add an additional MBBS degree following an MDS curriculum, or we should have a specialized training programs in the particular specialty fields like cleft and craniofacial or oral oncology programs. So after OMFS, we have various options like maxillofacial implants, maxillofacial trauma, oral oncology, cleft and craniofacial, and facial aesthetics. So coming to the cleft lip and palate, as I said, there are many needy people around us, definitely. And if you have a vision, and if you see in our community, definitely there are these people who requires surgeries. So is it just a soft tissue problem, and what is our role when we are addressing this particular defect, cleft lip and palate? Yeah, just correcting the lip and palate and leaving the patient will not is not going to help help the patient. All the patient needs is a comprehensive rehabilitation, like just not addressing the just the lip or just addressing the palate. We should know the consequences of that surgery and the consequences on the development of the face on the for the patient. So any of the mid-face hypoplasias following the surgery, or the dental anomalies following the palate repair, all these things we need to comprehensively address. And this is where we get the upper hand when we are dealing with this kind of particular problem, cleft lip and palate. We can address the cleft lip, we can address the cleft palate, and we can also address the mid-facial hypoplasias, which will follow the surgical repairs. So first we need to understand the problem, and we know what is the edge over this problem as a maxillofacial surgeon for this particular defect. And to choose it as a career option, we should know what are the training options available, and if we choose this cleft lip and palate, whether it is financially viable as a career option or not. That is also an important aspect when we are choosing this as a career option. So if we see a glance at the cleft, so we should know an in-depth analysis of the problems of this cleft. So how many patients are there, or if the patient is there, how many procedures we may need to perform. And always we should remember that first surgery is always the best surgery. Just address the lip and palate, leaving the patient, or do a lip surgery, and to correct those bad lips, it will take efforts to give the good results and good rehabilitation for the patient. So we understand, we know what are the consequences of this surgery, and we know what happens following the palate surgery, and we know the effects of this mid-face hypoplasia for the patient. So we know comprehensively how to manage these things. So definitely we can do much better better rehabilitation of these cleft lip and palate patients. So we require a comprehensive care, and we should understand the team should include each and everyone, right from the geneticist, nutritionist, pediodontist, orthodontist, including the good team of anesthesiologists. as well. And we should also have a proper basic foundation courses to choose this as a career, because I'll tell you one of my experiences. If you don't have a good team and a properly trained anesthesiologist, because all these pediatric cases, their hemodynamics are different. It is not just like an adult patient, and just by placing the tube in the patient's mouth and not leaving, not attending the baby during the surgical procedure. So when I'm having my experience, what my experience is when I'm doing my practice in the Shantiniketan, West Bengal, where there used to be a lot of cleft cases, anesthetists gave and they have used the, started using the halothane, and they went and sat outside, and suddenly the patient's blood pressure started falling, and nobody has any clue, but that's because of the halothane which is being used over there. So these are the things which we need to be very careful, not just having a cleft center or anything. We should have a proper basic foundation course where we should be trained adequately, where we should be we should know how to handle the pediatric patients. So these kind of curriculum is being introduced these days in all our medical, in all our dental schools, where in maxillofacial postgraduates goes to the peripheral postings, 1 year of peripheral postings in each and every department, like oral surgery, general surgery, general medicine, and anesthesia, all these postings. So the rehabilitation should be comprehensive, that the quality of life should be improved. So there lies our professionalism. So there are various training programs which are available. And so what is the difference from the past to the present? So in the past there are no dedicated cleft centers. Most of these cases are used to be addressed by, and there are very few trained surgeons also in the past. Before 2099, there are very few trained surgeons, and nobody used to address the secondary deformities. There used to be a huge backlog, volumes of backlogs of these secondary deformities as well. Once my senior has asked the Professor Shamarao sir, sir, you are operating so many clefts, and do you think that there will be so many clefts left over for the fellows who are going to come out from you? He answered, you just look at your community, you will see so many clefts in your community. So it is true, the incidence is same, and the backlogs are there, and there are so many patients who requires, there are so many needy patients who requires the procedures. So they are the pathfinders. Back in 2014 when I came and when I started introducing as a maxillofacial surgeon who is trained in the cleft and craniofacial, I doesn't need to convince them that a maxillofacial surgeon does these cleft lip and palate, because by the time our pioneers, that Dr. Goslar sir, they have already established, and they through them, most of the medical fraternity also knows the importance of a maxillofacial surgeons. And in our Andhra Pradesh, these two, like Goslar Reddy sir and Shivanagendra Reddy sir, they have already paved the pathways, and it is not that difficult for us or the coming generations to introduce themselves to the medical fraternity that we do these kind of cases. And we know that when they have started, especially Goslar sir, when they have started, there are no dedicated cleft centers. And of course, they are the first ones who have started doing the clefts, and the kind of difficulties what they would have faced in the initial stages, not difficulties, the challenges and how they have overcome, and it is truly inspiring. So the journey is not easy, and they have created a legacy, and it is our onus to carry forward that onus to, as a young oral and maxillofacial surgeons, to carry forward their legacy. So there are there are fellowship centers, and how we can train. There are IAOMS fellowship. This is for international students. Goslar sir offers this, and 6 months at Goslar sir's center and 6 months in Bangalore. And there are few university accredited fellowships also available from Krishnamurthy Gunantaya sir, and few other centers are there. As of now, there are no AOMSI fellowships, and definitely in the future there will be AOMSI fellowships will be available. And there are many centers which are offering observerships over here, or observerships. And because a fellowship is very important, because we should have a formal training. Unless we have a formal training to address this problem, we will not be able to treat these patients comprehensively. So once the formal training is over, it's how do we are going to sustain, or how are we going to fund ourselves. And there is a beautiful article what the challenges of Dr. Goslar sir's he has published in Journal of Craniofacial Surgery, starting and sustainability of a cleft and craniofacial center in a developing country like India. He has given a beautiful article, and he has explained everything, what are the challenges and how we have to overcome those challenges. So these are the organizations, international organizations, which will fund, and because most of these cleft patients are from the poor background. So we need to help them out, and there are ways to help. There are so many international organizations which will fund you, and they just don't come and ask us, you do the surgery and we will do the funding. We should show our results, and we should prove what better and how best we can treat these patients. Again, if we take these cleft lip and palate, we have a good research opportunities also. There will be sufficient databases will be available, and there are chances to interact with the institutes. And as this data will be systematically organized, we have a very good chance to have a better research opportunities. So we need to master the craft. So every lip is different, and there will be, the techniques are ever evolving, and our results should speak. The techniques are ever evolving because we have started from the straight line lip closure, and now we have reached the geometric advancement flaps, and we have reached the geometric advancement flaps. And we have an imprint. As an AOMSI members, we can proudly say that in this evolution of these techniques, our Goslar sir's article on Afro's incision for the base of the nose to camouflage the scar, it is published in the international article, and we follow that, and it gives the good results without any scar for the cleft lip surgeries. So the techniques have evolved, and we should master these techniques. So we should see our results, and sometimes we may need to unlearn that particular technique, and we need to relearn a new technique. So we should continuously updating our knowledge and skills each and every time. So we should have a strategy to achieve the goal, and we are creating these smiles with the scalpel, and we should know how to use that scalpel, and we should not misuse the scalpel. So this is our team at SNR SJDC. We have a smile train center since last 2020 March onwards, and we do the parent counseling. Initially, we do a parent counseling. This is very important because most of these families will be distraught in the initial, as and when they see this kid. So we have to thoroughly counsel the patient. We need to motivate them, and we need to make sure that they will come to the, they will get their kids for the treatment. And we give all these kids who comes in the first 2 to 3 months, we give the chance for them to have the pre-surgical nasoalveolar molding or pre-surgical orthopedics. So this will help to mold the nose as well as to reduce the alveolar cleft width. So we start this treatment with the within 10 days after the baby is born, once the complete cardiac evaluation and everything is done. So we do the nasoalveolar molding, and we are training our orthodontists and periodontists also. As of now, we are doing from the Department of Oral and Maxillofacial Surgery only. So these are the results of this nasoalveolar molding. It reduces the alveolar cleft width, and we can easily surgically close these kind of projecting premaxillas also without having tension. This is 7 days post-operative picture of this kid. So a thorough nutritional counseling is also being given for these kids, and we educate the mother and the family members how to feed these kids. And these are the few cases of the primary kiloplasty which have been done at our center. So this is the case which I have operated. So there are even the adult clefts which are unaddressed if we go to the rural and remote areas of our villages. So still these kind of cases, even they are there even to date. This is a bilateral cleft lip, primary palatoplasties, and we provide orthodontic treatment for the mixed dentition in the mixed dentition period. Alveolar bone graftings we do, late alveolar bone graftings also we do. We can see the nice elevation of the base of the nose without doing the alveolar bone grafting. Sometimes this helps before doing the rhinoplasties, because this positions the nose at a better platform when we do the rhinoplasty. So that is the advantage of doing these alveolar bone graftings. And permanent orthodontics for the for the correction of the permanent dentition. And orthognathic surgeries, we have not started yet with the distractions, but we have done few of the orthognathics in the last few months. This is the pre and post. So revision kiloplasties. So any of the surgical results, if we need to reassess, and if it is required, we have to go with the revision kiloplasties if required. And revision palatoplasties and revision fissulas, all fissulas correction. And rhinoplasties. So I conclude to say, if we do not change, we will be disqualified from the competition. If we do not want to learn new things and our thoughts and mentality stay old, we will end up with the time. Thank you.
May I now request Dr. Shivanagareddy to kindly introduce Dr. Gosla, sir.
Good morning, everyone.
It's a privilege and honor to introduce my teacher as a keynote speaker. And he's Professor Dr. Srinivas Khosla Reddy. He has done his BDS, MDS, MBBS, FDS, RCS, dual from Edinburgh and UK, and FRCS from UK, and PhD from Radboud University. And presently, he is a professor in the Department of Dentistry and Craniomaxillofacial Surgery at AOMSI Rishikesh from 2018 till now. And he is right now holds Hermann Zeller Chair at Krishna Institute of Medical Sciences, Karad. And he runs one of the pioneer cleft and craniofacial institutes in the world in the name of GSR Institute of Craniofacial Surgery. This GSR Institute of Craniofacial Surgery Institute is located in Hyderabad, and it is a 50-bedded hospital. And every year there are 1,500 surgeries that are taking place in that center. And totally nearly 30,000 free cleft surgeries has been operated as on date. And there are fellowships offered, 4 for national and 3 international fellowships have been offered. I am one of his first recipients of the fellowships. And he has trained more than 750 postgraduates and 60 fellows till now from the last 15 years. The institute is involved in robust research program. The institute, in collaboration with University Medical Center, Radboud University, is sponsoring PhD programs on topics like cleft and craniofacial surgeries. And right now they are running 8 PhD programs till date. And the parent body of GSR Institute of Craniofacial Surgery at Hyderabad Cleft Society runs a school for 100 underprivileged and orphan children born with cleft and craniofacial defects. And the school takes care of these children by providing them with tuition fees at a local school, free halls and residence and food. And he is a member of a lot of national and international associations, including Cleft Lip and Palate. And he's my teacher. And to conclude, I would like to say a few words about him personally, which he has taught me before I left the institute way back in 2003. I asked him a simple question, sir, can we be successful like this? How much time it takes? He simply said, do your work. It takes time for you to learn, and doing surgeries is a continuous process. You keep learning, and with success, you'll get money, you get name, and you get everything. And he's the best example to state that the hard work and the focus will make a man like him. And he's very humble and down to earth, and even today he receives everybody very nicely. And sir, it's my privilege and honor to introduce you as a keynote lecturer. Thank you, sir. Thank you.
Can I get the laptop? Okay, thank you. So sometime I can peep in. Yes. Okay, thank you. A very good afternoon, ladies and gentlemen. I take this honor. I take this honor to be here to give this lecture on the behalf of the AP State AOMSI. And I would like to take this opportunity to thank Dr. Aviraj and his team for putting this wonderful gathering together. Now, I've been asked on one topic because as the theme of this meeting is expanding the horizons, it's basically trying to motivate, encourage our younger generation, saying there is so much to achieve in our specialty. Now, this specialty is growing every year in different forms and different dimensions. So one of the dimensions is the craniofacial surgery. Now, what exactly is this craniofacial surgery? So I thought I would put it as what, where, when, who and how. Now, what is this craniofacial surgery? Now, we know that they are nothing but the abnormalities of head and neck region. They could be congenital, acquired. They could be acquired, could be trauma, neoplasms, whereas the congenital could be with clefting or without clefting. Now, where exactly is this craniofacial surgery performed? When you look at it, volume taggiyali. That's what, it's too high. దూరం ఉంటే తక్కువ స్పీడ్ వాయిస్ వస్తుంది దూరం ఉండాలి The craniofacial surgery is a surgery when you perform above this line, anything above the optic foramen. So optic foramen is the margin line where you say that you are a craniofacial surgeon or a maxillofacial surgeon. Now, what are the different malformations that we see in the craniofacial anomalies are craniostenosis, craniofacial dystosis, craniofacial syndromes and anomalies, cleft lip and palate, benign and malignant head and neck tumors, craniomaxillofacial trauma, non-syndromic orthognathic deformities. The best diagrammatic representation of the craniofacial anomalies the best way to classify them is taking up these zones. The A is nothing but the cranium, the B is the supraorbital area, the C is nasozygomatic complex, the D is the maxillary, E is the mandible. Now coming from down, it is the oral maxillofacial till here, and then this is the intermediate zone where it is, we can call it both as cranio-maxillofacial area. That is the C area. Now, if you extend yourself up, the B and A is called as a craniofacial surgery. So it is all based upon your competence of training exactly where you have to go. Now, coming to the craniostenosis, we know that majorly 4 types of stenosis that can occur. The plagio, that is oblique shaped, which is due to unilateral coronal stenosis. The trigon, the scapiocephaly. The brachiocephaly is the bilateral coronal stenosis. So for this, all you need to is identifying an irregular shaped head, take a proper CT scan of the skull 3D model, and then you can see easily where the suture is stenosed. Like as you see here, that the sagittal is normal, the posterior sutures, the occipital sutures are normal. It is the anterior suture, that is the coronal sutures that are fused up, so we call it as brachiocephaly. Now the other things like Cruzan syndrome, Pfeiffer syndrome, or the cloverleaf syndrome, and Teacher-Collins, Binders. You have different types of, again, anomalies regarding involving the mandible and the maxilla area, also sometimes the orbit, which comes under as a hemifacial microsomia. Now the new term is called as craniofacial microsomia, not hemifacial microsomia. Now where you have type 1, type 2A, type 2B and type 3. Or the Perrin-Robin sequence, as you see that the classical triad of a very retrognathic mandible with glossoptopsis and cleft palate. The hypertelorism. If you see this movie, The Avatar, you can notice that the imagination of the director, where he could really concept showing that way back we all look like these aliens. The hypertelorism is the increase in the intercanthal distance from the midpupillary line more than being 64 millimeters is called as hypertelorism. So this, the lateralization of the orbits is called as a hypertelorism. And we have cranial wall defects due to different format of the intracranial pressures. You can see the total posterior component of the cranium is totally resorbed out. We call it as the Dandy-Walker syndrome. You have the standard craniofacial clefts like Tessier 0, Tessier 2, that is a nasal cleft, Tessier 3, that is a naso-ocular cleft. Again, Tessier 4 is the oro-naso-ocular cleft. Tessier 5, again it is the oro-ocular clefts. tessier 7 is called as a lateral cleft. Again, a combination of these can happen as a tessier 3, 4 and 13 the same. And you have the simple incompletes, complete, incomplete bilateral, like a palate. There are different forms of all these comes as a craniofacial clefts. Again, you have the meningoceles and meningoencephalocele. The difference between meningocele and encephalocele is, you have to understand it, the simple thing is based upon where the extension of the neural involvement is. Then the craniofacial tumors like vascular malformations, you can see as a major ones to a very complicated as this. Then the neurofibromas, there could be benign tumors and malignants like sarcomas. And then the craniomaxillofacial trauma that is involving the nasoethmoidal fractures and the orbital fractures as you see here. These all come under the craniofacial surgery. The non-syndromic orthognathic deformities were involving the nasal complex and the maxillary complex where you have to do it together. So that is where exactly the craniofacial surgery is performed is as the examples of all these cases. Now, what is craniofacial surgery we have done? Now, when the craniofacial surgery should be performed? It is a very hierarchical thing to understand. It is all based upon the soft tissue has to be managed as early as between 3rd to 12th month, whereas the bone, if it is skull reshaping, you have to do it very early as infancy. The orbital rim advancement is done between 6 and 24 months. The anterior cranial vault reconstruction is done between 6 and 12 months. Again, the posterior cranial is done between 6 and 24th month. Whereas the mid-phase deformity can be done between 5 and 7 years, because this is mainly done for growth stimulation. And we have to make sure that the tooth buds are erupted, because the permanent tooth buds descend downwards by age of 7 years. So you can always make your mid-phase surgery. Whereas for the jaw deformity, that is the maxilla and the mandible, you have to wait for the total eruption of all the teeth. So who are the people who should perform the craniofacial surgery? Craniofacial surgery can be performed by anyone if you have this team. That is, most important, a hospital with equipment for managing neonatal, pediatric, surgical operating theaters for these and an ICU. If you don't have this, stop it. Don't call yourself as a craniofacial surgeon. If you're not working in a hospital which provides neonatal, pediatric surgical care, you need to understand, it's not a general hospital. You need to have the specialized people. Then when you're working in a setup, then you can call yourself as a craniofacial surgeon. If not, no. Then if it is there, yes. But the key is, who are the people involved in that? You need to have a neonologist, pediatricians, pediatric anesthetists, neurosurgeons, maxillofacial or plastic surgeons, or pediatric nursing staff are the key. It is not general nursing staff. Again, if you don't have, don't call yourself as a craniofacial center. Yes, if you have, then you call it as a craniofacial center. Craniofacial surgery, how is it performed? So the key is having the craniofacial treatment is pediatric anesthetists, neurosurgeons, maxillofacial plastic, pediatric nursing staff in the pediatric and surgical operating theater ICU. Then you can go ahead. So what do you do? Understanding the concepts of approach. For every craniofacial surgery, the standard approach is a bicoronal incision, a scalp incision where you deglow the total pericranium, leaving the bare bone. You can access till the level D, that is to the infraorbital rim. With this approach, you can approach the temporomandibular joint, the cranium, nasoethmoidal area, the orbital area, even the floor of the orbit and the zygoma. All level A, level B, level C, till just superior to the level D, that is inferior to the level C, is what you can approach with one single incision that is called as bicoronal incision. Now, craniostenosis, what you see here, you can notice that in this, the classical where the coronal sutures are stenosed, and then you need to, what you do is you raise a frontal flap. The frontal bone is totally exposed, removed. The anterior component of the cranium is exposed. You can see the anterior component of the cranium is exposed. You retract the brain posteriorly so that you can get access to the total supraorbital area. The frontal is exposed and the supraorbital area is exposed. And then you can totally cut the supraorbital rim out, you can see the classical trigon shape, the triangular shape of the bone. So you can mark it, and then you cut that into multiple pieces and you expand the bone. The one which is triangular shape can be expanded into a U shape. So the bone is molded, and then you can use the strips from other parts of the cranium, using it for augmenting the intermediate gap between the frontal area and the supraorbital rim. Because you're going to advance the this is a classical example of a trigon here. You can see the U shape of the cranium. This is the classical management of craniostenosis. Again, here you see a classical brachiocephaly, the flattened component. So again, what you do is you remove the supraorbital rim here, and this is one of our modifications where we make a V cut so that it jumps and interlocks here, so that the relapse is reduced. We make a VW cut here, and again, then the total advancement is performed. You can see the advancement of the supraorbital rim, nearly more than 3 centimeters of advancement is performed. So the brain can expand and the intracranial pressures can be reduced. And this flat forehead, you can notice that the proper contouring of the forehead is performed. The flatness, you can see the depressed supraorbital rim here. The eyes look shrunk and eyes looks popping out. The total orbital volume is increased by advancing the supraorbital rim. And this is the newer method. Now, when there is a multiple suture stenosis, as you see here, because of the increased intracranial pressure, the total shelling out or the honeycombed appearance of the cranium, what you see here. So what we do is we have stopped doing this so-called anterior cranial advancements. It's totally outdated in the last 5 years. For everything, we call it as a remodeling. We call it morpho-functional remodeling of the cranium, for which all we need to do is decrease the intracranial pressure. So how do we decrease the intracranial pressure? Simply enlarge the cranium. So how do we enlarge the cranium? So before we used to advance the anterior component of the cranium. Now what we do is increase the posterior part of the cranium. So by increasing the posterior part of the cranium, how do we do is we cut the posterior cranium, put 4 distractors, simple distractors, and push back the total posterior component of the cranium. Once you do it, you can see that the increase in the posterior cranial wall decreases the cranial pressures, and the patient, you can see the eyes which are popping out have gone inside totally. And this is a Pfeiffer syndrome, where there is a unilateral coronal stenosis with the severe high arch palate. So we did a total midline facial bipartition, the face that including the maxilla, nasal component, orbital component, frontal component. So D, C, and B, the 3 components are totally bifurcated and advanced. And then the gaps are filled, and we can use bioresorbable plates in this situation. We can notice that the total remodeling of the cranium has happened. And in a Cruzon syndrome, what we do is, again, we do a total fronto-orbital, nasal, and maxillary advancement. So we use the Leaford 3 and the Leaford 1 combination with the frontal component. So all A, B, C, D, all are advanced together. And then in a Teacher-Collins syndrome is a classical thing where there's a frontozygomatic suture is lacking, there's a missing here, and the zygomatic arch is missing. So what we do is we take the outer calvarium, carve it into the shape of a frontozygomatic arch, and then we fix it, and then we can create a proper lateral aspect of the eye. The Binder syndrome, where there is a total collapse of the midface, that is the infraorbital rim, the supraorbital inferior component, the nasal component, and the maxillary component. It's a classical dish-faced or the C-faced face. So we did a Leaford 3 osteotomy, did a zygomatic osteotomy, zygomatico-frontal osteotomy, nasal osteotomy, and a Leaford 1 osteotomy. You can see the frontonasal osteotomy. So we and then we taken calvarial grafts, did it as interpositional grafts, and advanced the maxilla, the naso-orbital component. The Leaford 3 goes along this area. So this the C component of the midface is advanced in one shot in binders. Like coming for hemifacial microsomias, you have different types. The simple thing is a very simple type 1 hemifacial where there's a simple jaw asymmetry. We can do a procedure called sliding genoplasty. You can just slide the chin out from the lesser segment to the greater segment. And again, a soft tissue type 1 where you need to know that there is a deficiency of the mandible on this side. So we did a soft tissue correction early, and then we did a distraction, and then automatically you can do the soft tissue correction and also advancement of the mandible at very early stage. Again, a type 2B hemifacial microsomia, the best is, this is the deficient side. So use a stock Medpore implant, angle implant, and then augment this deficiency, and then you can get a perfect facial harmony in both sides. In a type 3, what we did is we distracted. First, we did the distraction, and then we again augmented. Distraction plus augmentation can be best in type 3. In a Perrin-Robin sequence, what we call it is a neonatal distraction. The distraction is performed at very early stage in a months-old baby, that's sometimes even days old. And then you can see the total advancement of the chin and the mandible forward. The child can breathe normally. In hypertelorism, you can see there is a lateralization of the orbits. There is a total increase in the intercanthal distance here. So what we do is again do a bicornal incision, frontal exposure, retraction of the brain, then we cut the intermediate segment of the naso-ethmoidal area, because here there is a severe hypertrophy of the ethmoidal air cells. So we remove the total naso-ethmoidal area, the intermediate, do a box osteotomy of the orbits, and then we just by simple finger pressure, we can push both the orbits medially. So there is a total medialization of the orbits, and we take the split calvarial grafts. The calvarium is split into the center mid part, and all these grafts are used to fill in the defect that caused due to the mid, because you have moved the orbit from here to here. So there is a lot of gap here. So all that gap has to be filled by using bone grafts, and then this is the type of outcome you can get by reducing the intermediate component. A Dandy-Walker syndrome, a total loss of posterior part of the cranium. So what we do is we use two fibular grafts, non-free, it's a non-vascularized graft. We harvest it, split the fibula into two halves, use it as a framework, split calvarium and a titanium mesh. So total reconstruction, we push the brain inside and the reconstruction of the calvarium is performed. So you can see the total reconstruction of the posterior calvarium. Now we have this craniofacial clefts like a Tessier 0, 14, like we do the primary component of the lip with hypertelorism correction, and then the nasal reconstruction once the patient grows after 14 or 15 years, and this is the type of outcome we can get from a Tessier 0 starting from here. This is the same girl, now what she looks now. And we have our own design for managing of cleft lips, where we use it to call it as a morphofunctional design, where we use a Pfeiffer wavy incision on one side and a Millard rotational incision on one side, and these are the type of outcomes. Proper nasal and lip symmetry has to be obtained. The nose and the lip has to be created in a balance. Even in the bilateral, even a very rotated prognathic premaxilla, we don't do none. Good amount of muscle orientation. Automatically, you can see the projecting premaxilla like this. As a child comes to the 3 years age, it comes to the normal symmetry. A proper palate without creating any lateral gaps. The key is leaving any amount of scar here, gap here creates a scar, and then collapse of the maxilla. And then encephalocele, again, we had to do it along the neurosurgical approach. We do the frontal osteotomy. The excess component part of the brain that is hanging outside in the frontonasal area can be excised simply. And then we have to do an orbital osteotomy. Close the bony gap. Without closing bony gap, it will reoccur again. It pulsatiles and projects. So we have to close all the bony gaps, again tighten it up and put grafts sealing that area, and then this is what we can do. And vascular anomalies, it could be capillary, venous, lymphatic, arteriovenous, or hemangiomas. We always use sclerotherapy. A simple propranolol usage is more than enough to, simple oral syrups can reduce this sort of vascular anomalies to this sort. Surgical protocol is key is the accessibility. We have to have a harmonic scalpel, a huge vascular anomaly like this. You can see the high volume AV flow, very high AV flow can be excised if you have good access and good instrumentation called harmonic scalpel. And then hemangiomas like this, and then pediatric tumors, huge amount of pathologies like this where you can see, as I said, craniofacial surgery is done in pediatrics and neonates. So a huge tumor like this in adult is easy to manage. As the previous surgeon explained that there's a lot of skin to play around. But these sort of things, how do we reconstruct? We cannot do a reconstruction in months-old baby using fibular grafts. So we used a temporary measure. We used a simple silicone tube, an endotracheal silicone tube like this. We used it to use that, and then secondary bone forms along this tube and grows, creating a normal mandible, as you see. Huge craniofacial tumors involving the orbit, nasal, and the oral cavity. The total enlargement of the orbit. So we did the total excision of this, and sarcomas, you can see the total part, and then we did a maxillectomy, and then we did a simple reconstruction and closed that area. Normal symmetry. Craniomaxillofacial trauma, the total supraorbital rim is shattered along with the infraorbital rim. So we have used resorbable meshes for the lower orbit, infraorbital area, and the supraorbital rim again is reconstructed using titanium mesh. And then this is the type of symmetry. The balance and the symmetry of the orbits is important. And this non-syndromic orthognathic, we do procedures combined both rhinoplasties and leaf-out osteotomies. We have done a reduction rhinoplasty here, and we did a augmentation rhinoplasty here. So what you can see that we have done a rhinoplasty and a leaf-out one simultaneously together. So if you are managing craniofacial area, you can do similar procedures, that is nasal area and the maxillary area at the same time. And planning of a surgery is important. A severe asymmetry like this, yes, we can say I'll do a leaf-out one, I will do a mandibular surgery, but it's difficult. But augmentation, planning, 3D planning is important. So what we did is we did a mandibular augmentation, genoplasty for rotation, and a peak implant for the malar area. So from such a huge flattening, we can create a beautiful faces like this by using implants and bone surgery together. This is another girl again, where such a huge flat face, we have to use a lot of implants and mandibular surgery. So the goal of us as a craniofacial surgeons is to understand what, where, when, and who has to perform it. To perform it, you need to understand the zone A, B, C, D, E. Yes, we all start at the level E, that is oral surgery. We need to stepwise grow up to the A level. We are the team A, the A team. To become an A team, it needs a simple thing is practice, qualification, dedication, and most important, being focused. You achieve it. It takes 10 to 20 years minimum to achieve be a proper craniofacial surgeon, performing all levels, that is from oral surgery, maxillofacial surgery, craniomaxillofacial surgery, and craniofacial surgery. The key goal is getting the smile back. Thank you very much for giving this opportunity to be here today.
Thank you very much, dear Ghosla sir. That's indeed a great feast to the audience. Just by observing the cases of high-end craniofacial surgeries, I am glad that they're going home with abundant knowledge. We all will gather together again after 15 minutes, after a tea break. There will be a formal felicitation of all the speakers and the guests of the day. Okay? The scientific session will break for 15 minutes. We'll gather later. Thank you.
Secretary and Correspondent of St. Joseph Dental College, Reverend Father Moses Karu, onto the dais. Thank you, Father. I invite Vicar General, Reverend Father Bala Garum, onto the dais. Father is representing the Bishop of Elur Diocese. Thank you, Father. Now I would like to call upon our chief guest, Sri Kartikeya Misra Garum. He is the Collector and District Magistrate of West Godavari. Let's welcome him with a round of applause, please. Thank you, sir. Now Anne will give an introduction about our chief guest.
Welcome to the SJDC campus, sir. We are deeply appreciative of the time that you have taken out for us, sir. Now, if you would let me, I would like to brief about the journey of yours till now, sir. Kartikeya Mishra IAS initially worked at the Goldman Sachs Bank in the United States and later left the job and started pursuing for civils and later successfully got selected for civils. Sir was the 2009 batch of IAS officers. Sir became the Commissioner of Industries Department in 2014. And in 2017, he was the East Godavari District Collector, and there was immense development in that district in every aspect. In the year 2019, he was appointed as the Health and Family Welfare Commissioner, and in the following year of 2020, Sir was designated as the Special Secretary to the Government Finance Department and MD AP State Finance Corporation. Presently, Sir is the District Collector and Magistrate in the West Godavari District. We deem it a great privilege to have you amongst us, sir. Thanks a lot, sir.
Thank you. Now I would like to call upon the DCM member from the AOMSI, Dr. Mehboob Sheikh, sir, onto the dais, please. Thank you, sir. Now I would like to call upon our principal, sir, Dr. N. Slivras, sir, onto the dais, please. I would like to call upon the organizing chairman, Dr. S. Ravraj Kumar, sir, onto the dais, please. I would like to call upon Reverend Father Bala Garum to address the gathering.
Good morning, all of you once again. I think we are entering to the noon time. As I represent Most Reverend Jairao Pulimera, the Bishop of Eluru, and the chairman of VDMC Trust that runs the institutions in the campus, St. Joseph Dental College, St. Joseph General Hospital, and St. Joseph College of Nursing, I extend a warm welcome on behalf of His Lordship, the chairman, to our beloved District Collector and Magistrate, Sri Kartikeya Mishra IAS, and wish him all success in all his endeavors in bringing up the district of West Godavari as per his own ways, so that all the people in the district will have a wonderful period during his tenure. I also would like to give the greetings of the chairman to the Department of Oral Surgery, wishing the department a great success of this conference, state level conference, while recognizing the presence of stalwarts from other dental colleges in Andhra Pradesh and also the student delegates from every college, dental college from Andhra Pradesh. I also take this opportunity to say a few words on behalf of the chairman, that the chairman wishes this conference a great success and also appeals to the faculty and the students of this dental college to uphold the values of dentistry. That dentistry is not a kind of livelihood, but it is a vocation that we are called by God to serve people in any profession that we enter. So we have a moral obligation towards the society, particularly the poor in the society. That is why the Christian missionaries always speak about compassion. Compassion means that you feel one with those who are suffering. The other day, I saw in the media
from far places, the postgraduates and the head of the departments, they have reached all the way for this AP 13th AOMSI chapter conference. With lot of scientific knowledge, they planned this event here. I wish all the delegates and postgraduates to utilize these scientific sessions and go with some home message. I always treat the postgraduates, they are the real achievers. First they start their career as a small lamp. They cannot speak. They give the light. Automatically, once they finish the postgraduates, they will be like achievers. Achievers always speak only with their achievements. Like that, I wish all the postgraduates and delegates to enjoy this event. Thank you for giving this opportunity.
Thank you, sir.
Father Moses, Reverend Vicar, Dr. Sheikh, the principal of the college, HOD of the department, all doctors, dignitaries who have come to participate in this conference, and PG students. I thank you all for inviting me here, and I wish this gathering and these scientific discussions lot of success and fulfillment. Now, one, I don't know why I'm here, because I'm not a doctor, I don't understand much of it. But what I can share with you is my memories from King George Medical College in Lucknow, long time ago, when I had a dental issue and I had to go there, and some PG student experimented on me. And you take a impression, upar niche paina kinda, then you come up with something, and then 2-3 PG students standing on me and fussing over me, iska ye daant theek nahi hai, molar lo tappu undi, canine is also wrong, jaw has gone back, and I'm like, Babu, my face is open, you can talk later kada. And these fellows are like criticizing my entire mouth. All the time somebody has opened my mouth. And I'm like, water. And this fellow is not listening. No water for you till I don't finish my thesis on you. Quite a painful experience. So ultimately, what happened, there were 4 doctors, 2 boys, 2 girls. నా పళ్ళుకి ఏం కాలేదు, కానీ వాళ్ళిద్దరికి మ్యారేజ్ అయిపోయింది. Dr. Amarnath, I still remember, he's practicing, he's a very good doctor, very nice hand, steady hand. He's practicing in Haridwar. And so I told myself, I prayed to God that I should not come to a dentist ever again. Okay, what is this? These people open your mouth and they start having tea and your mouth is open. So when you do such kind of prayers, they never come true. So I had one RCT. Again, now the chap who there was some super specialty something in Hyderabad, and again you go for internship kada, with this large established doctor who is God, and under God you work so you can also become God. So there was a guy, now he's doing RCT, and after doing something for a while he says, I think the local anesthetic may be little less. That's not something you want to hear as a patient at all. That local anesthetic may be little less, and it was really little less. Then I remembered a poem by Ojan Nash. Ojan Nash is a well-known poet. He has written a poem in which he says, some pains are physical, some are mental, one which is both is dental. So आप लोग मतलब you have huge responsibility in ensuring that people should undergo physical pain but not the mental pain. Okay, people are very, somebody is operating on hand, leg, some other part of the body is fine, but somebody who's operating on your face, somebody who's an ENT or a dentist or orthodontist, the specialty, these are things where people are very afraid of you, but what to do? So therefore, my only request is, and I'm sure the way this college is structured and the way this college indulges in its pedagogy, this is something which is already a source of, an ingredient in your daily teaching and your daily exercise that you do. But you will become a great professional. You will be respected a lot. People will vie for your time, and that is what you are seeking, mind you. What you are seeking is that people should vie for your time. People should come to you. You'll do all that and much more than that if you have empathy for the chap who has come to you. This is very, very important, and this is something which in all our lives, whatever we do, if we have empathy for the individual or a group of people who have come to us, more and more people will come to you. You will become that much more successful, that much more practice you will have, that much more neatness your hand will gather, that much more divinity God will provide in your hands. And that is what I hope for each and every PG student who is seated here. Wish you all the very best for your careers and your lives. Thank you.
Thank you very much, sir. Now there is a felicitation for the speakers of the conference by our chief guest and the management.
Now may I request Dr. Gosla sir to kindly step forward.
Thank you, sir. Now I request Dr. Anantnag, sir, to please come forward for the felicitation.
Thank you, sir. Now, may I request Dr. Leela Krishna, sir, to kindly step forward.
I request Dr. Srikanth, sir, to please come forward. I also request Dr. Avinash, sir, to please come forward. Avinash, sir, please step forward.
Thank you, Dr. Srikanth.
Thank you, sir. There's a special felicitation for Dr. Mehboob, sir. As a DCI member, there's a special felicitation for Dr. Mehboob Sheikh, sir. There's one more felicitation from to the Mehboob, sir, from the management. There's two felicitations for the Mehboob, sir. final felicitation for our chief guest by the management and the chairman of the conference. Final felicitation. Thank you, sir. Thank you very much for your presence here. Felicitation from the management and organizing committee. Thank you, sir. Thank you very much. Thank you, sir. Now I'm going to read out the prize winners of the paper and poster presentations. I request all the prize winners to come forward and take your prizes from the organizing chairman. Round of applause. Thank you. The second prize for the paper presentation, Dr. Hema Madhuri from Anit Visakhapatnam. Please give her a round of applause. Thank you. The third prize for the paper presentation, Dr. K. Nagasai Reddy from the Vishnu Dental College, Bhimavaram. Give her a round of applause, please.
On behalf of Nagasai Reddy, the faculty of Vishnu is receiving the prize.
Now we have the prize winners for poster presentation. The prize winners are as follows. First prize goes to Dr. Vigneshwar, GDC Dental College, Vijayawada. Second prize goes to Dr. Suryamani Raj, Narayana Dental College, Nellore. There is a tie for second prize. The next second prize is for Dr. G. Natraj, Siba Dental College, Guntur. Third prize goes to Dr. K. Manikanta, SNDC, Gannavaram. Congratulations to all the prize winners.
Now the much awaited Dr. C. Ramalu oration, which is special to the AP State AOMSI chapter. It will be delivered by Dr. Tangvelu sir. And before that, Dr. Srikanth is going to give a brief introduction about Dr. C. Ramalu sir.
Good afternoon, one and all. It is a great privilege to speak about late Dr. C. Ramalu, who was first oral surgeon of combined Andhra Pradesh and Telangana. I am very proud and thankful to speak about such an eminent personality. Sir was born in the year 1933. He has taken his primary schooling from Pangaluru and elementary education in Eddanpudi village, Prakasam district. His pre-university was from Hindu College, Guntur. Sir has a dual degree as a Bachelor of Sciences from Government Degree College, Gudivada, and Bachelor of Dental Surgery from Government Dental College, University of Madras in 1959. Sir has earned his Masters in Oral Surgery from Nair Hospital and Dental College, Bombay in the year 1965. Sir has various courses in oral surgery from Institute of Dental Surgery in the year 1969 and from Eastman Dental Hospital, London, and also from the University of London and British Postgraduation Medical Federation as well. His services to the field of dentistry and oral surgery are remarkable. He has worked as a dentist in Government Dental College, Andhra Pradesh in the year 1959 and as an assistant professor in GDC Hyderabad in 1965. He was a professor and head of Department for Dental Surgery, King George Hospital, Visakhapatnam in 1971. Sir has taken his retirement from government services in 1991 and practiced thereafter as a general dentist till the year 2010. The sad demise of Dr. C. Ramulu on 5th September 2010 has no doubt left an irreplaceable loss to the field of dentistry and oral surgery. His contributions and his achievements to our field is a great inspiration and have laid a path for the younger generations to walk on and achieve heights. Thank you.
To deliver the Dr. C. Ramlu oration, Dr. Tangvelu sir has come all the way from Pondicherry. Right now he is a professor in Rajamataya Dental College and Hospital, Chidambaram. I feel humbled to introduce my guru and mentor. I was one of his postgraduate students from 2002 to 2005. Sir has completed his BDS and MDS both in the Rajamataya Dental College and Hospital, Annamala University, and later on he did his DNB, Diploma on National Board at Dharwad in 2001. Also, he is a fellow in Indian Board of Maxillofacial Surgeons, that is AP AOMSI. He served the Maxillofacial Association at various positions, both at state and national levels, and presented more than 350 scientific papers, guest lectures, keynote lectures, all over the country and abroad. Published more than 70 articles, in which 7 are original research and 12 articles are internationally high impact factor journals. Also, he contributed to a chapter in the ENT textbook by Dr. Sahu. As a student of him during post-graduation, I can speak volumes about sir, but to put it in simple words, we are always mesmerized by his passion, enthusiasm, and the spontaneity. Whatever any conference happens or someone asks him to just come and deliver the lecture at any time, even if it is a midnight, he's such a kind of spontaneous person. So his famous quote used to be aim higher when we are doing post-graduation. I hope that still he is using the same. Anybody who takes his signature or asks an autograph, always he used to mention aim higher. So that motivated us a lot, and we hope we lived up to your expectations following the post-graduation course. And with this brief introduction, I welcome Dr. Tangvelu sir to deliver the prestigious Dr. C. Ramlu oration. Thank you.
Thank you, Ravi, for the fantastic introduction. And I hope all of you are hungry. And I see a lot of cheers and lot of applauds for all the achievers and young students who have presented various papers in this conference and posters. I give my sincere applauds and appreciations for them, for their contribution to this association and this conference. I see a lot of seniors in front of me. I consider my seniors in Annamalai. We consider our seniors in Annamalai as our teachers. One of my teachers is Dr. B. Srinivas, who is from Vijayawada. He was my 2 years senior and he is there. I would like to acknowledge him for being my good senior and a wonderful teacher. And of course, Ghoshla Reddy was a universal and global teacher and global friend of most of the maxillofacial surgeons around the globe. And one of the few Indians who has taken this association and our fraternity to the global level, the credit goes to Dr. Ghoshla Reddy, one of my good friends. Today he asked me, because I used to nag him nowadays, get me some opportunities, I want to visit some centers abroad. He asked me at the age of 53, sir, you want to go abroad and see people working. Do you think you can come back and put your efforts and work as young as you were doing earlier? I told, no, I don't want to work faster or as you think, but I want to send that message to the younger generation, stating that such type of exposure in an abroad level and an international level is absolutely mandatory to improve your skills and knowledge. That is what I told him. So I thank him wonderfully for giving me lot of support during my learning in oral surgery, Dr. Ghoshla Reddy, because whenever he sends a report of his hospital and institute, we all used to see how much cases he has done, how he managed financial situations and things like that. Though we are not the member of the institute, he sends those details to most of us who's in the association and things like that. So a lot of applause to him for taking this association to great heights, because from Andhra Pradesh, from 1996, when we were counterparts and we were completed our postgraduates, I see Ghoshla Reddy in one frame, and every year he is leaping bounds and he is going to great heights. Not only him, he takes a group of people along with him and takes the association to great heights. Great regards to Ghoshla Reddy, sir. And I see two of my postgraduate students and junior colleague, Dr. Ravi Raj Kumar, Dr. Vamsi and Dr. Venkat Raju, who is also from Raj Mandir. My initial visits here were to inaugurate these two persons' clinic, one in Raj Mandir and one in Ravi Raj Kumar's clinic in Elur, and Vamsi also. So great regards to them, and I would like to recognize all the Andhra colleagues, Mehboob, and most of my friends here for taking care of me and introducing me to this younger generation and to give this oration. With all regards to everybody who is sitting in front of me, I am honored to give the lecture in the name of Dr. C. Ramulu. And as Ravi Raj Kumar has introduced the speaker, I also give my great regards to the Association of Oral Maxillofacial Surgeons, because this year they have given me two honors. I just completed an oration in the midterm conference which was happened in Dehradun, and it was called as Colonel Madan's oration. It was a great honor for me to give the oration. Though it was an online virtual conference, we had a good gathering of about 750 delegates, and we did the oration. And the second oration from the state level, I am really honored to stand before you to give this oration in this gentleman's name. So with all namaskars to not only him, there are a lot of such senior members who have contributed to the society from this part of the state. So with all regards to them and with blessings of them, I would like to share my little experience, which we call it as a BS School of Thought, because my mentor, my teacher is Dr. B. Srinivas. And B. Srinivasan is one of the pioneer legend oral maxillofacial surgeon from Tamil Nadu, and he was a direct student of Jeanwala. Whoever knows about Jeanwala, we also have a Jeanwala trophy in AOMSI. And he is one of the pioneer oral surgeon who started his early education in oral maxillofacial surgery. Imagine, we did a microvascular flap in 1996. We did a craniofacial surgery in 1996. I'll show you photographs of that. And we in our institute performed arthroscopy in 2000 itself. And though it was a very amateur stage where implants was done in 1994, and he was an ambassador of IT Stroman company from Germany, and Professor Kruger, Shelley, all of them came to Annamalai, all of them came to India, and they shared all the experience about dental implantology. So he was one among the senior members who have taken this association to great heights from our part of, so with all namaskars and regards to my professor mentor. I've come here to talk about changes and challenges. I saw three beautiful presentations before me with a focused topic. They really came to teach you. I want to throw light on various aspects of oral surgery and what are the changes which has occurred and how we are going to face the challenges which is kept in front of us in present days. So coming to the first foremost thing, the dental education. It is not political views I'm giving, it is just talking about the dental education. As a dental educationist for past 26 years, I see a lot of changes and a lot of policy changes in dental education. The 2-year course, originally the MDS course was 2 years. Today the MDS course is 3 years. Originally the MDS oral surgery was given to all dental should be utilized for the goods, and we need to cope up with those changes in the dental education. So I say that these changes of making 3 years course in MDS, making a medical college must for a maxillofacial post-graduation is some of the good changes which has occurred in the dental education. So the second thing what I would like to share is the patient's approach. So there are a lot of changes which has occurred. How do we approach when you impart a treatment on a patient? You have a cleft baby in front of you. We all know that the cleft is the problem for it. The patients will not be knowing about the post-operative speech. The patients will not be knowing about the post-operative growth. They only are worried about the problem what is seen outside, that is the cleft. So it is our responsibility to understand the disease in a holistic manner and to try to give a treatment in that aspect of it. So patient's problem alone should not be the base of the treatment. Today, we talk about a lot of evidences. Even Ghosla was giving a lot of evidences. Evidence-based science and evidence-based treatment is the landmark of today's treatment. If you say that this type of flap is failing for 20 times and there is no evidence of good post-operative results with this flap, never do that flap. You need not show dramatically that you are a great surgeon by doing great surgery which has got no success rate. So all the treatment based to the patients are nowadays evidence based, not problem based. I will show you some examples what we did in our college thinking that we are great surgeons. The third one is about the diagnostic aids. In yesteryears there was only one X-ray called an OPG, orthopantomogram. That was a gold standard for each and every diagnosis. Even today we do that in most of the hospitals. But still the advances like 3D CT, the modified spiral CTs, the three-dimensional reconstruction of the CT pictures, your CBCT for dental cone X-rays, all this has given lot of changes in diagnostic aids which helps us in better understanding the disease and better treating this disease with these diagnostic aids. And there are a lot of things which is newly understood. The occlusion was never spoken about. Only if you fight with a plastic surgeon, we used to talk about the plastic surgeon does not know occlusion. Only we know occlusion and only we are liable to do the plating systems and all mandibular fractures. True, but how many of us know what is occlusion rightly is? Even when we do orthognathic, we do not much care about these occlusions. So a better understanding of the diseases like pain. When a patient comes to you with a pain, there is no one can give a definition for that pain what the patient sees, and that is not a quantified also. So it is very, very difficult to understand a pain from a patient. So better understanding of newer diseases, concepts in pain, occlusion is very important
important nowadays when you want to treat and get a very good results. Of course, the surgical techniques, the technique is from open surgical technique. Everything is controlled into a keyhole procedures. We are only doing minimal access surgeries. We are not going into a maximum access. So we even implants. In earlier days, we need to make a big flap, raise the flap, then put the implant. Now only buttons are necessary. You create a buttonhole in the mucosa, then put a implant transmucosally. So the surgical techniques also has changed a lot from a concept of big open surgeries to minimal invasive surgeries and access osteotomy. So I will be covering all these things in my lecture with few surgical examples from my side and emphasizing on the role of adjuvant and supportive therapy also. So that is about the changes, and I told you there are a lot of education like this conference. Our AOMSI, our Basic Dental Association, all those gives us recurrent conferences, very periodic CDE programs where we need to go and update our knowledge, absolutely necessary. And there are a lot of peripheral postings which has been done for the postgraduate, where in their home college, if they can't see them. I used to send my postgraduates to Goshla Sar's Institute for cleft training. And similarly, each and every college sends to another area as a peripheral posting. Take those peripheral postings as a very serious issue, and you can learn a lot of things from the peripheral posting. So these are the avenues and changes which has happened in dental education. And don't sit down only with the Google and with your Apple phone and try to Google all the answers what your teachers are asking. Today when I asked one of my postgraduate what is viral sign, anybody say what is viral sign? Immediately they will take the phone and put a viral sign. How many of you can say what is viral sign? What is Tinel sign? What is Puck sign? What is Gurian sign? What is battle sign? Everything Google will answer. Okay, so that is true, but only thing is Google can give you only a very short information, and you will be bored up to go deep into that search to know the complete information of that. So that is not going to last long. It is going to be only temporary to answer or tackle your examiner or your professor. But if you want a lifelong knowledge about that subject, you need to take a book, and even books give you some only about a personal. If I am writing a book, I can give you only my personal experience and my personal experience with various surgeries. But today journals and journals with evidence-based articles like multicentric studies, your analytic studies, all those is going to be helpful in upgrading your knowledge and with a sound scientific basis. Okay, so that is about not to Google and go for journals for search, and have a hard copy of your journals when you have something interesting in it, and put it in your library for you to verify whenever necessary. And don't forget that you do attend the conferences and CDE program not only for credential points. If there is 12 credential points, if there is 6 credential points for this conference, it is not only for the credential points. You are appearing for these conferences and symposiums. You are learning from each and every one. You are socializing with your senior colleagues. Today you have an opportunity to talk with Goshla, to talk with so many people and know what is happening around us and what are the updates. So let me say something about, can anybody say what is this procedure? This is a preauricular incision where which the zygomatic arch is down fractured. And can any one of you say what is this procedure? It is called as Daughtry's procedure. Once upon a time, we did so many cases of Daughtry's procedure where there was an subluxation of temporomandibular joint or hypermobility of temporomandibular joint. It was a standard procedure, but what is this procedure is called as a glenotemporal osteotomy. You fracture the lower part of the zygomatic arch into 2 halves and put a bone graft in between so that the eminence height will be increased so the condyle does not move further forward. But only thing is, how many of us are doing these procedures today? there is no evidence for the success of this procedure. And there is a lot of controversy saying that when you do an augmentation of the zygomatic arch or eminence, it is only on the lateral aspect. You have the medial escape of the condyle. The condyle goes medially and anteriorly and it escapes, and there is a recurrence even if you do this procedure. So though it is very attractive, though the surgery was very good, but it has got no evidence that it solves the problem. So that is how you need to analyze, and you should not doing all these stunts. This was one of the articles which when I go to library, I take up some interesting case reports and articles. Once this type of plate, I don't know how many of you know about this type of plate, which is put on the zygomatic posterior part of the zygomatic arch and the eminence, so that the eminence height is increased. Whenever the condyle moves forward, it prevents the condyle from total movement. Here the medial escape is not there because it's a J-shaped projection which covers the entire anterior region of the glenoid fossa, so that the condyle will not go beyond that. There is no chance of condyle going beyond that. But this was an article which said it has got a good result. So immediately I gave a dissertation in 2006 or 7, and we did a dozen of cases like that, putting both plates on the in the eminence area, a J-shaped plate, and we called it as a condylar stop plate. And only then we realized that this condyle this plate is going to jeopardize the entire musculoskeletal system surrounding the condylar neck. So there will be some amount of resorption. There can be probability of resorption in the sigmoid notch. The condyle can even get resorbed because of constant play over this stainless steel material or titanium material. So that was though there are articles which is not evidence based, which is just a case report, which can attract you to do some cases, but it needs a sound evidence-based search about that procedure before doing the procedure and getting the results out of it. So this is one of the flap which is called a submental flap. Even this procedure, one of my Andhra Pradesh postgraduate did as a dissertation, and we did about 30-40. It's a nice flap which is called as a submental flap, and we just tunnel the submental flap along with the submental artery, a branch of anterior branch of the facial artery, and take it intraorally, especially in the floor of the mouth, the lateral border of the tongue reconstruction. Again, when you are going to address a cancer on that side, we are going to address the neck on this side. So it has got a limitations. Lot of things can have limitations, though you can't apply the same procedure for all. So Tanga sir has told about this submental flap, sir. Can we do submental flap when you see a lateral border of the tongue? A lateral border of the tongue with the neck involvement needs a neck clearance. When you're going to clear the entire neck on that side, where is the facial artery, where is the mental artery, where is the submental flap? The role of submental flap itself is not there in that case. So it should be analyzed in only a simple case where there is no neck involvement. We can plan for a submental flap. Again, it is a specific case-based flap. So those things should be analyzed when you learn, and you can see a beautiful picture of a radio lesion or a bony lesion here. This was histopathologically when we took a biopsy some 14 years back. Today the patient is 23 years old. I think we did the surgery at the age of 8 for this patient, and we saw a beautiful lesion here in the right side of the mandible, and the biopsy proved as a juvenile ossifying fibroma. Most of you will accept that juvenile ossifying fibroma has got a highest recurrence rate, and it should be treated aggressively. So considering the age of this little sweet girl, what we did was we did an intraoral resection and did a plating. There is no scientific evidence here to say that this intraoral resection for this age is an apt procedure. When we ask Anant about immediately why can't we do a microvascular, the microvascular will be the answer. So even considering this age group of patient, we did a resection and intraoral plating, and we only heard about regeneration underneath the periosteum from our teachers. But I told during the procedure, since she is a growing girl, we need not think of reconstruction, we will allow the bone to regrow. We will only take care of the periosteum and then suture the periosteum. So though there is no evidence, much evidence about this periosteal regeneration, all of you know that the inner layer of the periosteum is called as cambial layer of the periosteum. The outer layer is called as fibrous layer, which is always continuity with the muscle. The inner layer is called as cambial layer, which is always continuity with the bone. So the inner layer of the periosteum, cambial layer of the periosteum, has got the highest bone forming potentiality. When you repair this, this usually happens when you take a rib in an younger individual in TMJ reconstruction. If you take a rib, you need not reconstruct that rib. Automatically after some time during the growth, the rib regrows again. So because of the osteogenic potential of the periosteum. Similarly, we saw after 7 years, 6 years, we saw a beautiful bone there. And what we did is we removed the longer plate, and wherever the weak area, we thought it's a weak area, we just put a smaller plate and we left the patient, and the patient was functionally fine. After 10 years, 12 years, we did an implant recently for her, 2 bicortical implants we placed, and the entire height of the mandible three-dimensionally growed with good potential. I could not even remove this plate for putting an implant. The bone was totally covering the entire plate and the screws were very tight. So the quantity of bone which is regenerated without reconstruction in a growing child was excellent. And I failed in my surgery of removing this plate, and we planned only two implants on this side and 1 implant on this side in an oblique fashion. That is why we opted for a basal implant. So that is what happened with this. So what I'm trying to say is, even there is no evidence of doing something, certain surgical procedures we need to take a chance and see something can happen like this. If you have a series of 10 cases like this, even it will become a evidence. So you can combine such type of procedure as a multicentric study and ask inferences from various centers to have such type of details, and then you can publish it so that it becomes an evidence for the younger generation. So that is about evidences. So evidence not just decorating our clinic halls with all these certificates and all these mementos of attending conference. It is really the knowledge what we gain from the publications, and it should be a high rate of evidence-based search. It should be a systematic review, or it should be a multicentric study or something like that. And evidence plays a very major role in today's maxillofacial practice. Coming to the diagnostic aids, as I've told you, there are a lot of diagnostic updates, diagnostic aids and updates, and starting from a simple X-ray, what we can diagnose the zygoma. You have a 3-dimensional view, or you take a CT, it will give you an additional information which can change the entire treatment plan. Okay, because you don't have the facility, or the patient does not have the facility of spending some money and sending it for higher investigation. If you want to take the consideration of this picture alone and do the procedure, it might not be good enough, or it might not give. See, for example, if you take an OPG, I would not have seen this osteomyelitis condyle like this in my OPG. There is total absence of condyle, rudimentary condyle there. The patient has got severe trismus or having an extraoral sinus here, some type of osteomyelitis, post-traumatic osteomyelitis of the condyle, and the entire condyle, medially dislocated condyle was here, malunited, and some amount of irregularities seen in the head of the condyle. So all this picture, only if you have an advanced 3D imaging system or 3D CT, you can understand better. Because nowadays, most of the scoring of the disease, as COVID depends, the prognosis of COVID treatment depends only on the chest CT scoring, not on the temperature, not on the clinical picture. So most of the scoring, most of the severity indexes are lies with your imaging system, with your imaging diagnosis. So you have a Shenoy's classification. All of you know that the standard TMJ radiographic classification. Unless you know how much is the callus in the TMJ ankylosing, what type of resection and what type of reconstruction you are going to plan. So you, with an OPG, you can't say whether only the medial surface of the condyle is united or lateral surface of the condyle is united. Is there a pole of small anteromedially dislocated condyle? All these things will not be seen in an OPG. You can only understand there is a condylar fracture, for which either conservative or in the management. So when you want to analyze a TMJ ankylosis, especially that depends on a radiographic Topazian classification or a Shannon's classification. So these classifications and misindex score, mandibular trauma severity index score, that is called as MISS misindex. So all these things you can take an advanced radiograph and categorize the severity, and accordingly, like our internal dearrangement is scored in a MRI, what degree of severity of internal dearrangement in temporomandibular joint. So the severity of the disease itself is categorized recently with all this advanced radiographic pictures and advanced so for example, you want to do a simple impaction also. If you take a CBCT, if you ask anybody with a root involved or a root nearing the neurovascular bundle, you will say, okay, there can be a problem, there need not be a problem, the canal is closer, the canal is, you have a classification again for that. But still, if you have a CBCT, you can have a what type of root involvement to the crown, and whether it is mesially placed, whether it is laterally to the tooth or it is into the tooth, all those things you can understand with the CBCT. And if you want to do that, see, for example, this case, if you take and you can see a discontinuity in the upper border of the neurovascular canal, but only thing is we don't know how far that implies right. Can be the canal is distalized or lingually placed. So three-dimensional X-rays or CBCTs can give you more ideas for you to do a coronotomy or coronoplasty, what you call it as. So don't do a complete removal, you can just cut along the crown, or you can reshape the crown, which is having the favorability of foot impaction and things like that. So that is how these three-dimensional X-rays and three-dimensional pictures are helpful in changing your treatment plan today. Coming to the virtual planning, again, this has got a leap-bound interest in recent practice. I don't do most of the orthognathic, most of the reconstruction without a virtual planning or without a 3D prototype model, or what you call it as rapid medical modeling or rapid prototype models. Okay, we need to take the entire defect or a tumor, whatever it is, in a three-dimensional resin model, and you can make a custom-made patient-based prosthesis. What do you call it as a patient-based prosthesis? These prostheses are made patient-based. This is one of the cases which was recently done in government medical dental college at Tamil Nadu. They did an entire gigantiform amyloblastoma, excision of the mandible, total excision of the mandible. This was a three-dimensional custom-made or a patient-made, patient-based implant which was made by CTARS, and John Nason does a fantastic work from Tamil Nadu on planning, in virtual planning, and doing such type of custom-made prosthesis, custom-made, patient-made, patient-based prosthesis, specific implants. Okay, so that is one of the, and this is one of the virtual planning what we did recently for a mandibular hyperplasia, condylar hyperplasia. So everything, it's virtual, it's in the computer. You can go for a Zoom meeting with the John Nason or whoever is doing the virtual planning. You can turn the head to the right side, left side, up, down. Have an understanding of how big is the hyperplasia of the condyle, whether you are going to do a sagittal split, how you are going to correct the canth in the occlusion, the lower border bowing. All those things can be planned by a virtual planning method in recent years. So without getting these virtual, this is a condyle, this is the TM joint which we have, total joint transfer which we have recently done. And you can see a beautiful patient-specific implant which is placed in the maxilla along with the denture. Imagine we are putting a denture along with the implant and rehabilitating the patient in the same stage. We still don't know what is the success rate of these specific implants or the rehabilitation, but still it is the state-of-art innovation today for us to plan such type of procedures in virtually and with the use of medical prototype modeling. I told you about pain, better understanding of the diseases. You need to understand more about about the potential malignant conditions recently. So not all lichen planus or leukoplakia change into a cancer. So you need to understand what is potentially malignant conditions and lesions. You need to have more understanding about the pain. You need to have the influence of pain management with reference to the occlusion and the masticatory system. All this has become very, very important. So you can't say a patient with a temporomandibular joint pain immediately do a de-occlusion or remove the contacts from the teeth, increase the overjet. Only if there is a bruxism and only if there is a reduction in the vertical height, you need to give a bite raising appliance or a splint. Not for all cases. Or you want to intentionally increase the bite, you give these type of bite raising appliances. So that when you give intentionally raise the vertical height, you need to rehabilitate with that increased vertical height so that the muscle is getting programmed, you are de-occlusion, the occlusion is deprogrammed and your muscle is getting used to that deprogrammed occlusion. So that is how we need to understand and apply this temporomandibular joint pain, myofascial pain, facial pains and always compare it with the occlusion and the vertical dimensions of the face, and then you do the splint, or you can also use some sort of lasers and other physical therapies, exercises, mouth opening exercises, something like that, which still holds good in managing temporomandibular disorders and TMDs, what we call it as. Coming to the surgical armamentarium, we have lot of changes from chisel mallet those days to scopy assisted surgeries. We understand what are the changes. Today, we never think about doing a Cardwell look procedure to approach the sinus and remove a root which is slipped into the sinus. Immediately we ask our ENT surgeon or whoever has had an experience of doing a FES. Most of the dental clinics also nowadays are decorated with the endoscopic assisted sinus procedures. So they can put the scope into the middle meatus and go into the sinus and see where the tooth is and put a high vacuum suction and remove the toothpiece from the maxillary sinus. So the Cardwell look, the two great scientists who has invented Cardwell look is being overlapped by this recent advances of equipments. So you can't still say that that is the only way of treating. If it is a maxillary sinusitis, if there is lot of changes in the epithelium, you want to remove the epithelium surgically, even that can be done with the FES. So functional endoscopic assisted sinus surgeries have given more, something like that. The scopy can be used in each and every procedure what you want to do. If you want to know whether the zygomatic arch is reduced properly, with the same Gillies temporal approach, you can put a scopy and see whether it is reduced properly. If you want to see a condyle which is reduced properly and you are going to put a plate intraorally, you can do an endoscopic assisted condylar plating system. That is the changes of our armamentarium what we have. Using a transbuccal trocar, you can put reduce the condyle and you can put a plating in the only in the low level subcondylar fractures. You can do an endoscopic assisted plating system. Arthroscopy is taken a big way. A lot of people started doing arthroscopies, and arthroscopy lavage, arthrocentesis lavage is needle arthrocentesis. Arthroscopic centesis and lavage is by using an arthroscopy. You clean up the joint, you see it can be used both for diagnosing the intra-articular structures and also to cure the adhesion or scar formation in and around the temporomandibular joint, which prevents the smooth movement of the disc to the disc and the condyle complex. So scopic assisted surgery, when you go a little higher up and you talk with your neurosurgeons, they talk about gamma knife procedures for trigeminal neuralgia. Even today, patient walks in and around our dental clinic with neuralgia. We don't have anything other than carbamazepine 100 milligrams 2 times daily or 3 times daily. Nothing else we do. Some of them will boldly cut the peripheral nerve, but that cutting the peripheral nerve is outdated. That can be done in severe pain only to stop the triggers. Whenever there is a trigger zone is positive, then those areas you can cut the nerve so that the triggering is not there. Triggering is absent. See, for example, the patient says, when I put my hand in the infraorbital region, I have a shocking type of pain, sir. If this pain is severe and he always gets the trigger, you can cut the infraorbital nerve by doing a peripheral nerve avulsion. Or else, if the problem is going to be intracranial, what is the big point in cutting the nerve here? So you need to address the intracranial problem in neuralgia and the gamma knife, where in which the patient, you have a container like, and the patient head is pushed into the grally, and there will be a lot of gamma radiations which is focused onto the lesion, and that is called as gamma knife procedure. Gamma knife procedures have come in a long way, not only intracranially, even in abdominal procedures, they have started using these gamma procedures. Okay, so this is another technique. When you have a lesion like this in the ramus of the mandible, what could be this lesion? Anybody from the postgraduate students? What could be this lesion? Nobody, huh? It can be a odontome. It can be a fibroosseous lesion. So this is, you can see the entire ramus is, angle of the mandible is involved. The lower border continuity is not much seen. It's going above the neurovascular bundle here, and there is no much of sigmoid notch area. It can be obliterated also. It's such a huge lesion with an unerupted tooth. So when you want to remove this, 100% you will be removing a lot of bone on the labial side. Whether you are doing it intraorally or extraorally, you can't remove this encapsulated mass. It's encapsulated. It is as a definitive margin. So you need to cut it into pieces and then remove it, which will be a long time taking procedure. So access osteotomy, what we call it as, we do a lift osteotomy to approach the cranial base, anterior cranial base and middle cranial base. ENT surgeons usually call us maxillofacial surgeons to do a lift osteotomy or lift osteotomy to down fracture the maxilla so that they can do a craniopharyngioma or a cranial base tumor resection. So similarly, you have a Crockett's approach for the infratemporal fossa approach. So you want to remove a tumor from the infratemporal fossa. Where is the approach? You need to cut the zygomatic arch, you need to cut the coronoids, only then you can reach the infratemporal fossa. So through a preauricular approach, you cut the zygomatic arch pedicle to the masseter, pull it downwards. You cut the coronoids, temporalis is pedicle, pull it upwards. Then you can reach the infratemporal fossa. You can remove the infratemporal clearance. So this is called as access osteotomy. So sagittal split osteotomy can also be used for this case to sagittally split the bone without removing the bone. You splay open as you do it in sagittal osteotomy, remove the tumor in between, and then you can plate it. This is what we did for this patient. We did an access osteotomy. So this access osteotomy not only minimizes the surgical morbidities associated with the post-op. See, this is the intraoral same sagittal split incision. We make a same cut as you do for sagittal split osteotomy. Even though we have an inferior quality of bone on the labial side, we have fractured it and split it open, removed the tumor en masse, and then put it back and then put a plating here. So this is a pre-operative X-ray and this is a post-operative X-ray. The third molars have been removed. You can see the entire lesion is removed along with the sagittal split osteotomy. The same procedure is well-established procedure for odontogenic keratosis called as Brosh procedure, where the same type of lesion 15 years back I operated through an extraoral approach. As I saw, the entire mass was inside the bone here, see here, inside the bone here. So I don't want to lose this integrity of the mandible. So we went through an extraoral approach. We made an osteotomy all along the labial cortex from upper border, lower border. The outer cortex alone was removed and the tumor inside the medulla was removed. The outer cortex was curated and put it back with the plate. And this patient was doing fine all this day. So such type of access osteotomies without removing a lot of bone and cutting a lot of bone, we can go ahead. And the surgical techniques are evolved, and surgical fixative techniques, management of these things and all has improved a lot. So for example, a canine distalization. This is one of the procedure which is used by a surgical assisted orthodontics. What you call it as surgical assisted accelerated orthodontics. So what you do is normally a canine, for to distalize a canine, you extract the premolar, and it takes more than 3 to 4 months for more than 4 months to 6 months for distalizing the canine. So for that, we can do an osteotomy in that area. Premolars can be removed and create a gap distal to the canine and put a tooth-borne distractor so that once you start distracting, closing, open the distractor and put it. Once you turn the distractor arm, it will start closing, which will push the canine and distalize the canine. So this is one method of getting the canine distalized within 7 days of time. Imagine 7 months and 7 days. You can have have the entire canine distalized, and you can start moving your anteriors to the bone regenerate area in the distracted area. So this is one of the advanced techniques which, since though the equipment what we have used is a crude and a custom-made distractor, when you use a sophisticated canine distalizers, it is very, very good. This is a gentleman, I don't know how many of you have heard about him. He is Professor Najmi Nazar, and I got the contacts from Goshla Reddy, and he was materializing the program for me in Antwerp. I was with him for 20 days in Antwerp, and the entire concept of doing an orthognathic surgery and cleft on me was changed at the age of 50. I am 53 now. 3 years back I went there. When I saw him doing an orthognathic procedure, when I saw him doing a cleft procedure, he was doing a cleft lip addition for 30 days or 40 days old, 3 months old baby or something like that. So I asked him, when did you plan this procedure? He said, I planned this procedure 9 months before. The baby itself is only 2 months old, but he has planned the procedure 8 months before. So they have planned the procedure when the patient is in intrauteral period. They scanned the baby, they understood the cleft, and they have planned the surgery, and they put a timetable for that surgeries for the patient for another 1 year or 2 years. When to do nasal molding, when to do lip addition, when to do your lip, primary palate, all those things are planned intrauterine period itself. So when I was talking with him, he never does premolar extraction for skeletal cases. How many of you will accept that they don't do a premolar extraction itself when they want to do a skeletal osteotomy or orthognathic for class 2, class 3 cases? Because what they do is, for most of the cases, for skeletal cases, they do a procedure called, before the orthodontic treatment, they do a surgical assisted expansion. They create an osteotomy between the canine central incisors, and they do a Lefort type of osteotomy and put an IRAX screw-like expanders and create a space in the midline. So whatever crowding is there in the anterior region can be consolidated with that space available, and he does not do an extraction of premolar. That was one technique which I learned from him. And they have a standard palatal distractor, which is a bone-borne distractor. He puts one hole on this side, one hole on this side, snaps the distractor in between, and then after turning, the palate entire expands after some time. So they start before orthodontic, they create a space, they correct the vertical and sagittal dimensions of maxilla mandible, and then start the fixed appliance, and within 1 year of time they consolidate, they decompensate everything, correct the crowdings, then take up the surgery, where the excellent post-operative result, the occlusion is just like that, because he has planned everything before, and the orthodontist who is working along with him does the orthodontic for the surgery, not like us. And this is the orthodontist. I saw 24 cases on a single OP day of younger generated orthodontic cases, where both orthodontist and the oral surgeon sat together and discussed and planned and gave a treatment protocol for 24 new patients. I will vouch, and I have never seen any of such orthodontic oral surgery planning in any of the institutes or any of the places in India till today. I am not aware of it. So it's very, very difficult to have such a cohesive response by an orthodontist, and that gentleman was very good. He took me to the robotic theater where he is getting the training of robotic surgery, and he has done robotic procedures for cleft lip and palate. So that was my experience at the age of 50. I put not to show off that I've gone here and there, because there are so many people who have gone many places, but I want to say that such type of experiences abroad, and with the better hands, with the better learned people, with better experienced people, always gives you wealth of knowledge and science, and only with that you can go up and up the ladder, or else it will be very, very difficult. Thinking that only Tanga sir is the best surgeon or Raviraj Kumar sir is the best surgeon in the world, if you think that and sit down here and learn, you will be only knowing what we know, and you will not be expanding your knowledge. So that is the reason. One theater day, he did 8 orthognathic procedures. Have you ever heard about doing 8 orthognathic bimaxillary procedures? 8 orthognathic procedures from the morning till evening, and 20 minutes for one, 25 to 30 minutes for one procedure. Lefort one, down fracture. As I say, he does in the table. He makes the cut, he makes the down fracture, he puts the plate, he makes the sagittal incision, he makes the down. As I say, the procedure is over. He cuts, and he has got 8 Martin kits in his OT table, 8 to 9. How many number of cases he does? He has got that number of kits in his OT. So only then we can do 8 cases, or else we will be using our osteotome. You will be washing, one PG will be sterilizing it, one PG will be rubbing it with some Savlon and then doing the osteotomy again. That is not possible. So that is the standard of maxillofacial surgery today. And he does calls his assistant or trainees, and the only trainees fixes the main part of any orthognathic procedure is fixation. I never leave the fixation to my postgraduate because I think the fixation is only very good. All his trainees do the fixation for him. All transbuccal trocar, 2 minutes they give a small stud incision, go into the ramus, they just catch hold of the osteotomy fragment, then drill 3 holes and put the screws to fix the sagittal split. So he is one pioneer who has done the sagittal split fixation only with screws, only with bone screws, 3 screws, something like this. He does that. Okay, so that is the lot of advances I've done in the surgical training, and these are some of the recently, after coming back, I did, after getting the experience from Antwerp University, I did few cases according to the principle what I learned, and the results were very good, and we were able to do some good work. Sorry, I don't know how, okay. So that is what I was saying. And the armamentarium also. See, we have a lot of armamentariums. When you want to, there is an increased incidence of osteomyelitis in post-COVID scenario. In our center, last month alone, we operated 6 COVID, non-COVID infected and COVID infected patient, which we thought it is a sort of mucormycosis, but it was not a mucormycosis. It was only an osteomyelitis. All were diabetes patients. So medically comorbid patients, the incidence increases of osteomyelitis. We should know what is hyperbaric oxygen, what is the role of hyperbaric oxygen. It is not only for question and answer session in Viva. You should clinically apply it and then send those patients wherever these armamentariums are available. The laser has come a big way. We do a lot of laser procedures as a low intensity laser therapy, LILT, what we call it as, for pain management, for inflammation management. I know one of my pediatric surgeon, friend of mine, he called me once and told, Tanga, my mother-in-law wanted to go for a scaling, but the dentist who is working in Vellore is asking 30,000 rupees for scaling. How much? 30,000 rupees for scaling. Can we give this and get the scaling done? Then what is that he is planning to do? I didn't understand it. He told me that he is going to do a laser scaling. Okay, fine. Whatever said and done, 1 week's whether hand scaling or laser scaling, 1.5 weeks later, the prognosis and the thing is going to be the same. I leave it to you. You decide whether you want to do a laser scaling there or come back and do a ultrasonic conventional scaling for no cost. He brought the mother-in-law to our hospital and got it done. Why I am saying this, if you have an armamentarium of that standards in your hospital, scientifically proved, it has got good anti-inflammatory effect, bacteriostatic effect, periodontal health, regeneration is good with lasers. All this thing is proved scientifically also. So these type of additional armamentarium in your dental clinic and your practice is going to improve the practice. 10 years back, we never used to put any type of bone grafts, any type of GTR membrane. Our failure rate in implants were about 20 to 25%. 10 implants, we put 2 implants might fail 10 years back. But today, 10 implants, you put 10 implants is success. Only because of such armamentarium where you can put off some bone grafts, do good adjuvant procedures like sinus lift and things like that, and put some GTR. Wherever there is a dehiscence, soft tissue dehiscence, wherever there is a bone insufficiency, try to put a bone graft. Don't think that it will take up, you can't take it for granted in in implant procedures. So this adjuvant procedure of putting a bone graft, taking a regional bone graft and putting it in the area of interest before doing an implant, after doing an implant as given. So that is about the changes, what I want to bring it to your notice. All these are the changes what we see today. But what is the challenges we have within among ourselves? These are the challenges. One most important thing is the comradeship and a team approach. As most of the speakers told, team approach is very, very important. Team approach is from the beginning, not doing an orthognathic surgery and sending the patient for post-operative occlusal correction. That is not the team approach. You plan the team approach before itself when you want to do the orthodontics, whether pre-operative or post-orthodontic. Understanding the medical conditions is more important. Without, so today there is no third-year medical posting for most of the hospitals, most of the dental colleges. They don't know to see the pulse. They don't know what is hypertension. They don't know what is glycemic index. They come out as a dentist and they practice dentistry. Where without knowing what is glycemic index, what is AP AOMSI, most of the postgraduates also don't know about these things. So unless otherwise you are very familiar with the general health and the comorbidities, you can't do a successful surgery. This is where the challenge lies. So I want you to be at least a quarter or a half physician before doing maxillofacial surgery. That is why in UK and abroad, Western countries, they make it mandatory for a medical degree to be a maxillofacial consultant. Without medical degree, you can't be a maxillofacial consultant in Western countries. That is the reason why I insist my postgraduates, my undergraduate students to learn more of medicine, more of general health, more of medical emergencies for you to equip yourself to handle better. And you also need to know about rarer diseases and how many of you have experienced a conscious sedation, a treatment or a surgery under conscious sedation. Any postgraduates have seen a conscious sedation? Doing a surgery in conscious sedation? See, though there are the drawbacks with conscious sedation, there are a lot of indications for conscious sedation. All pediatric surgeries can be done under conscious sedation with the help of anesthetist. So you need to know more about this conscious sedation. Apply. I know one of our senior member, first batch student of Annamalai, who is called as Shivakumar Srinivasan. He is famously called as Tall Shiva. BS will be knowing it. He is an anesthetist for maxillofacial surgeons in US. He goes only to give conscious sedation to various dental clinics and does conscious sedation, does implant procedures. Somebody will be doing the implant surgery. So there is the avenue for you to cope up with learning anesthesiology for dentistry. As a maxillofacial surgeon, you can know better about all these conscious sedation and things like that. So as I told you, comradeship, these are the few orthognathic cases which I did during the COVID, or in the intervals of COVID. I should not say during COVID, in the intervals of first wave and second wave and third wave, and in the intervals of COVID, this one class 3, which was an orthodontically treated. And why I want to show you is the difference between orthodontically treated and non-orthodontically treated. The patient had a orthodontic pre-surgically, had the decompensation done, and I did the surgery for her. And this was the patient who just walked in, and he does not have any type of orthodontic. I saw some 10% relapse on this patient when compared to, this is another surgical first orthodontics. Surgical first orthodontic technique is a technique not to do the surgery. As I told you, do the surgery and send for occlusal adjustment to orthodontics. You need to plan the surgery with an orthodontist so that the orthodontist understands better. After doing the surgery, they will do the settling the occlusion and settling the occlusion. Whatever subtle changes in the occlusion, they will take care of it. So this is one open, very challenging cases. All the anteriors were vened. All the tooth were vened because of enamel hypoplasia. The patient had a severe anterior upper bite. This was virtually planned, and I took up, this was a Coimbatore case, and we took up and we did a occlusal anterior open bite correction by jaw surgery. And this is a prognathy. You can see a huge prognathic mandible. She was walking all throughout the COVID days for her to get corrected because she had a total collapsed dentition. She was not having any time to go ahead with her orthodontic treatment. So we did the surgery, and now the orthodontics are tackling the occlusion. So surgery first is you can do the surgery, but only with the opinion of orthodontist. Don't do the surgery and send the orthodontics. When there are some situations where we are forced to do some cases, even if the surgeons, neurosurgeons are not available, in considering the Comerad SIP, we accept that we need a neurosurgeon when we go near the cranium. But if there is a complex fracture in the zygomatic arch or a panfacial injury where you need to address all the fractures, we need to go in for a coronal approach. It is only an anterior table fracture in the frontal sinus. And these procedure does not need a neurosurgeon unless otherwise there is really a head injury or there is really a intracranial problem. If the inner table is strong and the outer table alone is compressed, most of the procedure is done for the aesthetic considerations. So you can just open up the flap. The easiest flap what you can open up is the bicoronal flap. Though it looks big, it is very easy. You put your fingers and then you can just strip off the entire calvarium in a supragaleal or in a subgaleal plane, whatever you want. And that is what some cases you can't say that give an excuse that we don't have a neurosurgeon, that is why we didn't do it. Then we can't be doing most of the cases because most of the centers are not associated with. Some cases which can be easily handled by maxillofacial surgeons should be handled. Now, I think we lost this patient with the mucormycosis. That is why I put the heading as pandemic learning. Because this angiotype of mucormycosis occurs, if it occurs, if it is an angiotype, it takes only 2 to 3 days. And there was a patient with such signs after an extraction with comorbidity of diabetes 420 plus diabetes status, and he had a problem of swelling after the extraction which was done outside. And within 2 days of time, you can see the amount of ophthalmic changes, the ophthalmoplegia, all the signs of transcranial involvement. So such type of cases are very, very aggressive in nature, and you need to immediately jump on to the diagnosis and treatment planning of doing an aggressive clearance. There is no courtesy and there is no chance of living back something and thinking of doing something conservative. If you see a classical sign of mucormycosis, whether with COVID or without COVID, post-COVID or pre-COVID, whatever situation, if you suspect a mucormycosis, the treatment is aggressive and you need to remove the entire maxilla, whatever is involved. See, you can see the entire zygomatic arch, entire anterior wall, posterior lateral wall, thickening of the maxillary sinus. We removed whatever we can do and then sutured with the temporalis muscle. We did a temporalis muscle. There was a controversy during the pandemic learning that temporalis muscle should not be given because we need to observe the site of mucormycosis then and there for the prognosis and recurrence. Always leaving it open is always a good thing in mucormycosis. So the era of surgery has changed from the resection. We were doing only resection in olden days. Then today we have come to the era of tissue engineering. Every year, every era, reconstruction, regeneration. Regeneration is something with distraction osteogenesis. I will just run through the challenges what we have in trauma. If you have a panfacial injury along with the floor of the orbit reconstruction, absolutely we can have a rapid prototype modeling and we can plan for a orbital reconstruction. So this is one of the panfacial injuries. We have done a rapid prototype model. We have done a surgical stimulation, refractured, aligned all the fractures in that area, zygomatic arch, infraorbital region, maxilla, nasolateral region. Then we went through a coronal approach. We plated the maxilla as per the principle, in, out, or bottom up, or whatever it is. So you do the zygomatic arch reconstruction here by means of plate. All this is very challenging because the panfacial injury, especially panfacial injuries, are associated with head injuries. And most of the initial period of time, we can't do a primary treatment for them because they will be comatose or they will be having a very low Glasgow Coma scale and they will be in ICU. And they will turn up and come to you only with a post-treatment defects. So you need to correct it as a residual deformity of maxilla. So that is a challenge we have in tumors. This was thought that it is odontogenic keratocyst. We took a biopsy and we did a radical en bloc resection and sent it for biopsy. And the biopsy turned out to be a squamous cell carcinoma arising from the cystic epithelium. So such type of diagnosis can also need to intervene you again and do a corrective treatment. So we waited there for 1 year. The patient had no neck nodes. So we took the patient for rehabilitation and did, with the help of plastic surgeon, we did entire mandibular reconstruction with free fibula. This was the initial procedure. I did the resection because the incision biopsy result came out as OKC. So we started doing the resection. We resected it. The resected specimen biopsy result came out as squamous cell carcinoma arising from the OKC. So the treatment is not complete. The first diagnosis, they only specifically took a small portion of the cystic epithelium, saw it was odontogenic keratocyst. The second slice, what they took after the second resection, representative of squamous cell carcinoma. So we need to do second surgery for this gentleman, and we took a free fibula, waited for 1 year, and then no neck node, no recurrences. So we did a free microvascular free fibula, and the patient had an implant, and it's more than 7 years without any problem. So these are the challenging. So the biopsy plays a very major role. Whenever you see a huge cystic lesion, don't think it is only a cyst. Any part of the cyst would have changed into a different pathology. So you need to go for a thorough histopathological examination and confirmation of the disease. This is again a Brzezinski 3 of the entire, you can see the canting of the occlusion, you can see the entire coronoid condyle ramus complex itself is absent. This patient came from Tirupur to us, and it was really challenging for me because I have not done so much of craniofacial. I only have assisted few surgeons regarding that, and simple works we have done, but I planned with the rapid prototype model, as Gosla was saying, we thought of doing a genioplasty to correct a mandible. We augmented this ramus for some time. We did a vertical subsigmoid osteotomy for us to correct the occlusal canthing. We did a Lefort one osteotomy to do the occlusal canthing correction, and this was the phase we could give. And secondarily, we did with fat grafting on the left side of the face. Cleft again, this was another interesting case, an adult cleft where the patient had planning for a maxillary advancement. So I was asking few people, and Bhagwan Das has done good work on anterior maxillary extension, distraction. You do a Lefort one osteotomy sort of thing, and then advance the anterior maxilla alone in cleft if you can't do a total maxillary advancement by means of orthognathic surgery. So we did that procedure. More than 11 to 12 millimeters of maxillary advancement was possible, and you can see the distractor in place and the advancement in the anterior maxilla. We have done an osteotomy here, and we have also done a vertical reduction genioplasty. So distraction has come a very big way, and it's a great challenge. Most of the whoever has used the distraction have felt some failures in it, no doubt about it. If you do with the correct apparatus, with the correct vector, and understanding the distraction principle, it has solved lots of the problems. In temporomandibular joint, we have done a series of cases before resection of the temporomandibular joint. You can see the entire neck chin angle, flat, retrognathic mandible, chin, facial asymmetry, all that is corrected by the distraction. Only a simple distractor on both sides can do multiple correction. One side it can be corrected 16 millimeters, one side it can be corrected 18 millimeters within a period of short time, and you can take up for a reconstructor of joint. So this is again, you can see a flat chin neck angle, and you can see a good prominence in the chin by means of distractor. I think 14 to 15 millimeters of distraction we have done. All this is a conventional distractor, is not a high-end distractors, because if you use those type of high-end distractors, we will get a good. This patient again recently reported with me with a vertical ramus distractor. It is really a challenging to do a vertical ramus retraction along with genioplasty at the age of 4 years or 5 years. We did 10 years back. The patient has a restricted mouth opening, but still the condyle, the ramus shape, everything has come very good, and facial appearance is very good.
This is an extra-articular ankylosis. Just to say that we need to utilize the available material itself. You are resecting some material, the same material can be used as an augmentation material or as a reconstructive material. So what I did was, this was published from my unit, and we did a resection of the entire zygomatic coronoid complex. We separated the coronoid bone from the zygomatic bone, and zygomatic bone was replaced again, and then the arch of the zygomatic. This is what Ghosla also told about your trigonocephaly and some of the cranial malformations which occurs in early age group. And we did distraction. You can see the distraction, how this was only an intraoral distractor. At that time, 10 years back, Suresh Khanna, who is presently abroad, was doing a post-graduation under me, and we did this case. And you can see the amount of distraction and the expansion of the cranial vault with the distractor. That is how the intracranial pressures can be made into control. This is the surgery which I assisted by professor and a pediatric surgeon in 1994. And today, after so many 27 years, 26 years or 27 years, he is a first year MD student, MD, he finished his BBS and MD, and we did a series of cases for him. We did a maxillary advancement, we did a mandibular setback, anterior open bite correction, and earlier in 1993 we operated for his Cruzon's syndrome. So the earlier you do such type of disease, the better the results are. And as he told, we didn't have much of plating system those days. We expanded the entire vault into 3. We put some bone grafting here. We increased the collapsed orbital areas, orbital rims, and we increased the cranial volume so that the patient's milestone was normal. So there is a paradigm shift from extensive surgery to keyhole surgery. You have options of doing a lot of keyhole procedures anywhere in the thing, and do little conservatively also. Instead of radical resection, you know what is dredging procedure. In odontogenic keratosis or amyloblastoma, you don't do a resection. You do an enucleation, leave it for some time, again do an enucleation, then slowly after some time the disease will be cured. So conservative procedures in a younger age group or in a very old comorbid associated patients should always be considered. The help of surgical splines, surgical guides. You have a beautiful guide for doing a sagittal split osteotomy. How many millimeters you need to get, there is a gap there, you can do a cut. You can put a same sort of surgical guide in the maxilla. See, we have done a lift out one osteotomy. This is a surgical guide where in which there will be two airplane-like wings which will go adapt into the bone, and you can cut above this and above this. That is the osteotomy line what was pre-planned. And this is a lower border mandibular reshaping procedure for that condylar hyperplasia. This is a template and surgical guide for doing a condylar resection and putting a total joint transfer. So all these surgical guides, templates have come a very easy way of doing the procedure with good results. And with this aids and surgical navigation, we can do better. What I still insist is you go beyond, because today's theme of this conference is going beyond the horizon. So go beyond all your borders to achieve something. And if you can contribute to research, it is going to be another additional value for our profession. We started doing small project works with Dr. Vikraman, and so many PhD scholars are under me today. More than 6 PhD scholars are under me in the university. But my only advice is, whoever want to contribute something to the society, go into the research, and postgraduate has got a big avenue in research. We want Indian researchers, and research option is very open to all of you. So to go great heights, the solution is accept and take the responsibility of major maxillofacial work. Don't be content with your minor work, even though you are earning better. Little by little, you need to go do a craniofacial level of work. Only then we can prove our profession is capable enough to walk along a plastic surgeon and a neurosurgeon. Don't go hide yourself when a plastic surgeon or a neurosurgeon is walking in front of you. Go boldly in front of them and say that I can do a cranioplasty. Okay, that should be the professional talent what you guys should achieve. And this is one small video to relax yourself after my boring lecture. Here, this is from a recent movie. Volume,
recent movie called as, you just see that white boxer. He's called as a dancing rose in that movie. So he does attracts, and with his foot movements and his leg movements, he does the procedure. Sarpeta Parambaran, or latest movie in Tamil. I was very much attracted by that dancing rose character. And dubbed in Telugu also, okay. So see that dancing rose. I want to say just oral surgery is like dancing rose. It will take us to any level. It will be compromising us. It will be bimurtifying us. But only thing is you need to have a strong experience and knowledge to fight back that oral surgery as dancing rose. That is what I wanted to tell you here. And not only with the surgical skill, don't think that only with the surgical skill you can go ahead with doing all those things, because surgical skill is not enough to perform surgeries. When something goes wrong during the surgery, your scientific basic knowledge is very, very important. So reading text, reading subject is more important. Understanding the subject is more important than learning a surgical skill. The third year for undergraduate or final year undergraduate, they want to do an extraction. Whether it is wrong or right, they want to hang on a tooth, they want to shake the tooth like that, and they want to remove it and say that I have done an extraction. That is not the way of learning. You know how to catch hold of the forceps, how to give a rotational force, how to give an apical pressure, and how to do a traction. All these things you should technically learn, and only if you have the scientific knowledge you can learn all these skills, or else it's very, very difficult. So surgical skill alone is not enough. You can't get the surgical skill by seeing once what Ghoshla Reddy is doing or what Ravi Raj Kumar is doing. You need to have a basic scientific knowledge, and only with that scientific knowledge you can go better. So this is one of the recent messages. I don't know, some of you would have got it about a daffodil principle. There was one lady working in abroad, it seems. Mother has gone there for holidays. That girl told her, "Ma, you have not come to me to the daffodil garden. Come, I wanted to show you the daffodil garden." So mother said, "No, ma, my grandsons or grandchildren are there. I will be playing with them. I am not interested in seeing this daffodil garden." So there was a snow there, and mummy was somehow every day when the girl called her for a trip to daffodil garden, she was postponing things. It is snowy, it is raining, you can't drive the car properly. For all the hurdles, this girl took the mother to the daffodil garden, and he saw the entire hilltop was filled with the golden carpet like daffodil flowers. And the mother was really astonished to see this golden carpeted hill. And he said, "What? How it has happened? Who did it, or how it has happened?" Then the girl told, it was only one bulb at a time. It was only one person with 2 hands, 2 legs, and 1 brain who did all the work. And it started in 1958, mummy. So that old lady who was in the town came back to this village, and he took up this hill. He started planting one per bulb, one day from 1958, and today he has seen a beautiful golden carpet of daffodil flowers. So it is that the persistent, the focusedness, the amount of hard work they put. Similarly, if you start in your earlier age, you do with your 2 legs, 2 hands, and 2 brains, do a good surgery, learn everything, you can be a successful oral maxillofacial, ladies and gentlemen. I thank you for giving this opportunity. The only word and only mantra is be a hero. Always say, "I have no fear." Oral surgery, fearful person or a person with no courage can't do oral surgery. If it is bleeding, okay, let it bleed. Put a gauze and wait for some time. The bleeding will stop. That should be the intention of any surgeon who is operating. Maxillary artery, it will be bleeding. You can't do anything near the condyle. So if it is bleeding, okay, put a gauze, wait for some time. Do all 3 P's. It will be stopped.
That is what my teachers told us. Finished. That should be the courage. Be a hero. Try to do all the work is possible given to you. The future I see, it's very colorful, gracious, flourishing, scopeful. See the change, see the changes which happen and take the challenges. There is only one good word, knowledge, and only one evil, which is ignorance. Best wishes to all of you. Be a scientific surgeon and don't be a mechanical surgeon. Put all your hard work. Wish you all the best. And I once again thank the opportunity given to me to give this prestigious oration to the Andhra State branch. And thanks to all my team members who love maxillofacial surgery. Thank you, ladies and gentlemen.
Isn't it inspiring oration? What do you say, postgraduates? So I can see at 2 o'clock all of you are hungry, I know, but the half of the auditorium, more than half, around 70 to 80% of the auditorium is still full. Okay? By this time you could have understand why we have chosen Tanga sir for this oration, to inspire you and to bring out what way better possible the maxillofacial surgeon scope can be explained by him. Thank you, sir. That is indeed a great pleasure to have you here and listen to your lecture. Way back in 2006, once you had come to this same auditorium, maybe the auditorium is not AC that time. It's an open auditorium from 2006. I joined in this institute on 2006. He has come and inaugurated my clinic. It's almost 17 years after, 16 years after, again, the same oration is repeated here. And I am thankful to him for readily accepting the invitation and delivering a beautiful oration on Dr. C. Ramalu oration. Thank you, sir.
Thank you, Ravi. Thank you for patient listening, and go have a beautiful lunch.
Lunch is arranged just outside the auditorium, just once you enter into the car parking area. Placards have been kept, and we have 2 more guest lectures after the lunch session. Have your lunch pleasantly and come back. Okay.
From Government Dental College, Vijayawada, and post-graduation from Manipal College of Dental Sciences. He worked as a professor in Sudhanageswara Dental College, Gannavaram. Sir is a master and mentor for immediate loading implants in various workshops and is certified by International Implant Foundation, Germany. He has delivered many keynote lectures in various international and national conferences and is a frequent speaker on basal implants, pterygoid implants, and inferior alveolar nerve bypassing. His field of interest are immediate loading basal implants. Sir is currently working as a consultant implantologist and mentor in various workshops. Now I take the immense pleasure to call upon Dr. Professor Leela Krishna sir to deliver his keynote lecture. Thank you.
Good afternoon, everyone. Today my topic of presentation is on pterygoid implants. Before going into the topic, I would like to thank the organizing committee, Dr. Ravi Raju Garu, for inviting me to give a lecture on this pterygoid implants. It's a pleasure for me because I started my career in St. Joseph Dental College. I worked 1 year when I completed my MDS. After that, I went to Pinam in Siddhartha. So I feel that I am coming back to my home ground. So coming to the pterygoid implants, he is Mr. Stefan Ide. He is considered to be the father of the basal implants, modern basal implantology. Oh, sorry. Okay. Up.
It is a changer. Change it.
Okay. So the pterygoid implants normally is not a correct word. Normally they have to be called as tuberopterygoid implants because this implant goes from the tuberosity to the pterygoid. So if you want to talk strictly, you have to say it as tuberopterygoid implants, and it is defined by the glossary of oral and maxillofacial implantologists as implant placement through the maxillary tuberosity and into the pterygoid plate. So factors that make maxillary rehabilitation, that is dental rehabilitation, difficult are the most commonly you face very poor bone in maxilla, that is D4 bone, the resorbed ridges, sinus pneumatization, and then the resection and the bone defects, which are in the present scenario of the COVID the most common cases. Added to this, we can add the trauma cases where there will be bone loss. You need to when you want to rehabilitate the maxilla, it will be a difficult task. So you can see in this case, there is very poor bone, even all on 4 or any other possibility will be a difficult task. So some more cases like that. You can see here the bone is very scanty. Here this is a periodontitis case causing severe bone destruction in a 35 years old male, and this is of a 55 years old male where you can rarely see any bone other than the cortical bone. And this case, very common in present days because of the post-COVID effects. You can see the resected maxilla. Restoration of these cases will be a difficult task. But you have various options like zygomatic implants, pterygoid implants, all on 4, wide error implants, shorter implants, distraction. But each one has its own restrictions. Normally, when you see a resected case, the zygomatic implants and the pterygoid implants in combination can be used to restore those cases. But when you come to a severely resorbed ridge or a very poor case where there is poor bone, or you call it as knife edge, you can restore it with pterygoid implants because it provides the distal abutment, avoiding the cantilever. Minimal bone will be there in the anterior region where you can engage the implants to the nasal floor. So what are the advantages of the tuberopterygoid implants? So first of all, we should know what is a pterygoid. Pterygoid is a cortical bone, highly mineralized. If you have the habit of looking into CBCT of patients, when you move your cursor towards the pterygoid from the normal maxilla, the Hounsfield units will be almost 3 times that of your maxillary tuberosity or remaining part of the maxilla. So why? Because it's a fully corticalized bone and it is a buttress, pterygomaxillary buttress. What is the function of a buttress? The buttress function is to absorb the forces from the maxilla and distribute it to the base of the skull. So basically, it is designed to take up the forces. So if you place an implant into the buttress, it is into an advantageous position. And moreover, this buttress, pterygomaxillary buttress, is having the pterygoid. The lateral pterygoid place, which is attached to the muscles, will be having always active muscles. Whenever there is an active muscle attached to a bone, that will keep that bone always in a highly mineralized state. But one thing you have to keep in mind, this bone is just 6 to 7 mm thickness. You can't just push the implant beyond that, then it will become loose. So you have to keep that in mind. And one more thing is, the armamentarium or the instruments needed for the placement of the implant are very minimal. The implants which are used for the placement in the anterior region, same implants can be, same drill bits and the same thing can be used for the pterygoid also. So it's a non-invasive, basically because it's a flapless technique, it can be loaded immediately, minimal or nil complication, and no need for any secondary surgical procedures and no need for any cantilever following the placement of a pterygoid implant. It has high success rate. 93 to 95% success rate is reported in various articles. If you go through the articles, you can come across that. So the pterygoid is basically engaged by macromechanical fixation into the third corticals. To know about third corticals, I will briefly explain you what is a cortical. So here you can see This is the first cortical, the green line, that is your alveolar bone cortex. The second bone is the floor of the maxillary sinus, and then the nasal floor. These are second corticals. Third corticals are outside the maxilla, which is fully corticals. We, the oral surgeons, we use it for suspension in case of panfacial fractures. Something like your orbital rims, then zygoma, and then the pterygoid. So many people say that pterygoid is difficult and it's complicated. How difficult it is? No, not for oral surgeons. Maybe it is difficult for others. So to know that, you need to know a little bit about the anatomy. I will be running fast through the anatomy. The landmarks which you need to know about this pterygoid is maxillary tuberosity, pterygoid plates, pterygoid fossa, pterygomaxillary fissure and fossa, and the pyramidal process of the palatine bone. So these are the pterygoids coming down from the junction of the greater and the body and the greater wing of the sphenoid. This is medial pterygoid and this is lateral pterygoid. Lateral pterygoid will have attachment of medial pterygoid muscle and the lateral pterygoid muscles. So this is the maxilla and this is the pterygoid, which is a part of the sphenoid bone, and this is pterygoid hamulus. So this forms the pterygomaxillary junction or pterygomaxillary buttress. This is the area where you have to concentrate for placing the tuberopterygoid implants. Here you can see this is the medial pterygoid plate and lateral pterygoid plate. Lateral pterygoid plate larger than medial pterygoid plate because of muscle activity going on here. And the space between these two plates is the pterygoid fossa. So this is the pterygoid hamulus. Pterygoid hamulus, once you put your finger into your soft palate, you will be able to feel that sharp point. It gives the medio-inferior extent of your pterygoid. So by keeping a finger on that side when you are doing pterygoid implant, you will not be going out of your boundaries. So this is the same pterygoid hamulus in a different view. This is important picture which you need to know. This is pterygomaxillary fossa and this is pterygomaxillary fissure. Okay, this green line is the zone where you have to place your pterygoid implant. Whereas this is the area where you have to respect because it contains the vital structures which are to be saved. So this is the picture showing the pterygomaxillary fissure and fossa in an OPG. So the vital structures, you should know a little bit about the vital structures located in the pterygomaxillary fossa. You have the maxillary nerve, posterior superior ulnar nerve, then descending palatine artery, internal maxillary artery, pterygoid muscles and pterygoid venous plexus. If some of these structures are damaged, it is not going to cause any acute emergency. Only acute emergency can happen if there is damage to internal maxillary artery or descending palatine artery. So from the lowermost point to the uppermost point of the pterygomaxillary fissure, the average length reported by various studies is 21 plus or minus 2 to 3 millimeters it will be. So 23 millimeters you can count. So normally you never place a pterygoid implant straight. You place it in a slightly inclined fashion. So by placing it in an inclined fashion, you underpass this pterygomaxillary fossa. So thereby avoiding the vital structures. If you go straight, something like this red line, you are going to land directly into the fossa and thereby you can damage the vital structures. So this is the picture of the blood supply over there. This is the maxillary artery, descending palatine artery. After that enters into greater palatine foramen and then it becomes greater palatine artery, and this is the nasopalatine artery. And this is a relation of the descending palatine artery with the hard palate. So the procedure, coming to the procedure, first thing you have to check is mouth opening should be perfect. Otherwise it will be very difficult to do the thing. And third molars, all third molars should be extracted. Whether it is lower or upper, it has to be extracted. Procedure, instruments used, drilling sequence, starting point of osteotomy, angulation, number of implants, length of implants, and number of cortices. We'll discuss these things. See, these are the instruments which we use for placing a pterygoid implant. No special equipment needed. And this is the hand grip. Hand grip is just to have better access for placing the implant. And you can use it as an osteotome by using this hand grip osteotome instead of using a motorized drill. Whenever you are going to begin with the pterygoid implants, it is always better to use a hand osteotome rather than a motorized osteotome. These are the drills normally used: twist drill and pathfinder drill. The length of the drill what you use depends on the amount of the bone existing there. This is the hand grip osteotome. Whenever you use it, you can tap it something like your chisel and mallet. That is the best way of doing for the beginners. So this is how it is used, and this is the direction. So normally you read in a textbook, posterior superior ulnar nerve block, you go upward, inward and medial. It's the same direction, but you go through the bone, there you go in the soft tissue. Upward, medial and backward. And this is how it looks from the occlusal view. Point of entry, from where you have to start entering into the alveolus. It's from the either from the tuberosity or from the second molar or from the third molar, but never from the first molar. First molar will be too far from the pterygoid plates. From there also you can place pterygoid, but you need almost 30 plus mm of implant length. And moreover, when you place prosthesis, you will be placing teeth up to first molar only. So beyond that you will not be able to place. The pterygoids will be left free of occlusion. Only the prosthesis will be provided support by the pterygoid, but not any occlusal load. So if you place implants in the first molar, the difficulty is you can't place teeth over that. So it should be slightly distal to that, either second molar, third molar or tuberosity. So this is how it looks. So when you place an implant straight, only one implant will be possible, and the chances of injury into the pterygomaxillary fossa also will be very high. But when you place two implants in an inclined fashion, if this is the pterygomaxillary fossa, you will be underpassing, you will be going from below it without damaging or without chance of damaging the vital structures. So the anteroposterior angle, if you go into the Google and search for what is the anteroposterior angle for pterygoid implant, there are many articles which report it as 70 degrees, but that is for single implant. Okay, but if you want to place two implants, what is the advantage of placing two implants? The prosthesis, particularly cementation type of prosthesis, if you have two abutments, the chances of dislodgement will be very rare. So always try to place double pterygoid. If not possible, you can go with single pterygoid also. So 70 degrees is for single implant. If you want, this angulation is with Frankfurt horizontal plane. If you want to place two implant, it should be either 30 to 40 degrees to Frankfurt horizontal plane. So point of entry at second and third molar region of two implants, you can see the anterior one going through the second molar and the posterior one going through the third molar region. This is how it looks. So some textbooks and some articles says the implant, pterygoid implant, has to go through the pyramidal process of the maxilla. Maybe okay, but not always. The pyramidal process of the maxilla is located only in the lowermost portion of the pterygomaxillary fissure. So when you are placing an implant in the distal most portion of the maxilla, you will be able to encounter it. But when you are going anteriorly and going through the sinus and into the pterygoid, you will not enter the pyramidal process of the maxilla. So this is the osteotomy order: alveolus, tuberosity, sinus, posterior wall of maxilla, pyramidal process of palate and bone, and pterygoid. And this is how it looks from the occlusal view, slightly inclined towards medially. So single or double pterygoid. Double pterygoid is preferred, but if you are not able to place the double pterygoid, don't mess it up. The pterygoid fractures very easily. Okay, the posterior one is placed first, followed by the anterior one. See, the anterior one is longer in length when compared to the posterior one, because you are traveling a longer distance to reach the pterygoid. The posterior is placed first. Why? Because you have a better access. If you place anterior first and then posterior, then it will be difficult to do the procedure. So starting point of entry, buccopalatal angulation also has to be discussed. So this buccopalatal angulation varies with the point of entry of this burr. For example, you are starting in this closer to the buccal cortical plate. Then you need to angulate more to reach the pterygoid. If you are starting something like in the pterygoid root socket, then you travel almost straight. So the principle what you have to remember is your burr should be parallel to the lingual palatal cortical plate. If you go along this palatal cortical plate, you will be reaching the pterygoid. If you are coming from buccally, then also you should have an idea of reaching the pterygoid, keeping your eye parallel to this palatal cortical plate. So the buccopalatal entry, you can see this implant is entering close to the palatal cortex, and this one from the buccal cortex. You can see the difference in angulations. So it depends on where you start. The buccopalatal angulation differs based on your entry point. And then when you come to edentulous ridges, you can see this edentulous ridges, there is no buccal cortical bone much left behind. But when you see this, there is a big chunk of ulnar bone left behind. So normally what they say is you start 3 to 4 millimeters to the medial to the buccal cortical plate. When you start there, you have to go more medially. But here you need to go almost always straight in case of edentulous and severely resorbed cases. This is the same of different direction, and this is the pterygoid, and this is the maxillary sinus posterior wall. So the posterior wall of the tuberous, you can see this is in line with the palatal cortical plate. This is how the two implants will look. And then the length of the implant always is a concern. Minimum 15 millimeters and plus should be used. Otherwise you will not be reaching the pterygoid. Normally it is decided by the amount of ulnar bone left behind. The length of the implant will vary. But normally what they say is minimum 15 millimeters implant has to be used. Otherwise it will be in the tuberosity only. So this is normally 21 plus or minus 3 millimeters. So the length of the implant varies when you start from this green line and when you start from this blue line. So from here if you start, you have to use a longer implant. From here if you start, you have to use a shorter implant. And then the amount of bone loss, if it is mild, moderate and severe, the length of the implant also will be, if it is mild, then longer implants. More severe bone loss, you have to use longer implants. This is already discussed. Anterior implant longer than the posterior. Longer anterior one. Okay, this is the longer anterior one and a shorter posterior one. So how it looks clinically after the placement of pterygoid. You see all the implants are in one direction. These implants will be in a different direction. They will be angulated, antero-posteriorly directed. Okay. You can see in this case also. See this? So these are directed, the head of the implant will be directed mesially. See this? You can see. And this is how it looks after placement of prosthesis. The last implant is just taken as a support, but not for prosthesis loading. This is how it looks on the radiograph. These are the triple pterygoids and this is double pterygoid. So type of implant, when you come to basal implants, we have two types of implants. One is smooth surface and rough surface. But whenever you are going through the air spaces, that means maxillary sinus or whatever it is, we prefer to use smooth surface implant because the chances of infection will be very less. So these are the various types of smooth surface implants we have. And then the diameter of the implant always is a question mark. So the diameter is always, a smaller one is preferred. Why? Because if you use a bigger one, there can be chances of pterygoid getting fractured. Normally we start with 3.6 diameter. Larger one will be used only when the smaller one becomes loose, and if we want to get a better grip, then we change to larger one. Unless and otherwise, we go with only 3.6 mm. Number of cortices perforated. This is a different topic and it needs discussion at least half an hour, but I will try to just explain you in briefly. This is the maxillary sinus and this is the alveolar cortex. So when you start drilling from here and going like this is the first cortex, second cortex, and the posterior wall of maxilla is the third cortex, and then you enter into the pterygoid, that is the fourth cortex. In some cases, the pterygomaxillary fissure is widely separated. In some cases, the pterygoid and the posterior wall of the maxilla are fused completely. In that case, only one cortical perforation. So don't get confused with number of perforation. Normally, when you are putting a plate in the mandible, you start drilling from one side to the other side, you feel 2 cortices. But here, it can be 2 or it can be 3 or rarely it can be 4. So this is how it looks. So this is the first cortex, second cortex and third cortex. And see here, this is full maxillary sinus pneumatization. Starting from here, you have one first cortex and directly entering into the pterygoid. Posterior wall and pterygoid are fused. So you have only 2 cortices. Here on the opposite side, you have 4 cortices. Like that, it varies. So if you have done pterygoid on one side, don't feel that it will be the same picture on the opposite side. It differs. Things not to be done when you are doing a pterygoid. Never ever place any occlusal load on the pterygoid. It should be taken as for a support for your prosthesis, but never for occlusal load. Occlusion should be placed till first molar only. Drawbacks: normally the pterygoid anatomy is very much varied. It varies from case to case, and there is no well-defined protocol to place the implants. It depends on how much you practice and how much you are able to understand the anatomy. Then only you will be able to place the implants. Tactile sensation is the main guiding factor. Restricted mouth opening can pose difficulties. Prosthetic difficulties because of the angulation. Unless and otherwise you have a trained technician, you will have too much of difficulty. Implant placement is guided by individual and no consensus. And then what are the difficulties or the complications that can happen? Displacement into the sinus, displacement into infratemporal space, fracture of pterygoids, bleeding. And post-operative trismus is one of the common thing if you drill too many times, because pterygoids will be damaged, but that is not a big issue after 15-20 days. So I will go through the cases, few cases. So this is the first case I was showing. So this is resected maxilla. So you can see these are the anterior implants and this is the zygoma and this is the pterygoid combination used. But for this, how the prosthesis is given, this is the rim, metallic rim fixed over it, and over it, you give a denture kind of prosthesis which is having a soft liner over that. Whenever patient wants, he can slip it over this bar, and then he can remove it whenever he wants. So that is some kind of semi-fixed prosthesis. See, this is one more case where the bone is very less, restored with, and this is single pterygoids. Always you need not go for double pterygoids. Whenever it is not possible, just go for single pterygoids. And this you can see only very minimal bone is there. You can't use either all-on-4 or whatever it is. This is how it was restored using double pterygoids and then anterior basal implants. This is the post-op picture. And see this, how much bone is there in this case? Very minimal. So this case is restored with single pterygoids on both sides. And this is, there is an impacted tooth. The tooth was removed, immediately implant was placed, and this is a 4 years follow-up case. And you can see a pterygoid, in the pterygoid region, a drill bit is fractured. Pterygoid is sometimes very tough, and the patient, if the patient moves during that time, the chances of drill bit fracture is very high. So this is one more case of double pterygoid on one side and single pterygoid on one side. This is for the segment, and you can see the segments, and this is also segment. And this you can see this is a double pterygoids on both sides, and you can see double pterygoids on both sides. Double pterygoids, very minimal bone you can see. In these cases also, you can restore the maxilla without much difficulty. And this is how the prosthesis is given. You can see the maxilla is having very minimal bone, restored with double pterygoids on both sides. This is how it looks. And severely resorbed maxilla because of periodontitis, 35 years old male. You can see this is restored with double pterygoids and basal implants in the anterior region. This again you can see the amount of bone is very minimal. You can see it's restored with double pterygoid on one side and one pterygoid on left side. This is the prosthesis with prosthesis. This is the case where there is nil or minimal bone, where other options are not possible. This is one more case of minimal bone in the upper region. Double pterygoids on one side and single pterygoid. You can see all the implants are crossing this white line. What is this white line? White line is the cortical line, the nasal floor, the sinus floor. So the perforation of the cortex is a crime in two-stage implant. But here it's a rule and it has to be done with intention. So this is again a 5 years follow-up case, single pterygoids, and this is again double pterygoids. This is again double pterygoids. Sometimes the cortical bone will be very tough. It happens that the implant gets fractured over there, and you can see the amount of bone over here and how it is restored with double pterygoids. And moreover, the thing what you have to see is the fit of the prosthesis should be perfect. The prosthesis, normally what people do is they open up the undercuts and make the prosthesis. That will give a ill-fitting prosthesis, and the chances of failure of your implants will be very high. So the prosthesis should be perfectly fitting to the implants. You can see this was done 6 years back, and the patient came recently for upper double pterygoids placed on both sides. And this is again one more case, double pterygoids and single pterygoid. Double pterygoids on both sides. Again you can see a drill bit fracture, double pterygoids and single pterygoid. This is how the prosthesis looks. And you can see the amount of bone in this case, double pterygoids on both sides, double pterygoids. This is how a prosthesis, ceramic prosthesis can be made. And this was the last case, double pterygoids on both sides. Thank you.
Thank you very much, sir, for your scientific session. The last scientific session, Dr. Avinash Reddy, sir. Now, Soundarya will give an introduction about Dr. Avinash Reddy.
Good afternoon, everyone. I, Dr. Soundarya, take this great opportunity to invite one of our distinguished speakers. I, Dr. Soundarya, take this great opportunity to invite one of our distinguished speakers, Dr. Avinash Bhavanam, and it is a real honor to present his accomplishments. Dr. Avinash sir has completed his graduation from Vishnu Dental College, Bhimvaram, and his master's in oral and maxillofacial surgery from St. Joseph Dental College, Eluru. He also obtained PGCI in advanced implantology from Manipal, F5COI in implantology from International Congress of Implantology, USA, Fellowship in Implantology from Savita University, Chennai. He is now a PhD scholar in facial cosmetic surgery and hair transplant surgery. He is a certified hair transplant surgeon from ISHR Affiliated Center, Mumbai, and a certified facial cosmetic surgeon from Trinity Aesthetics Academy and Mumbai. Apart from this, Dr. Avinash sir has acquired a special educational qualification, which is a double master's degree in maxillofacial plastic surgery and implantology from prestigious universities as well as international fellowship. Sir is presently working as an assistant professor in the Department of Maxillofacial Plastic Surgery and Cosmetic Surgery at Paniniya Institute of Hospitals in Hyderabad. He is a consultant hair transplant surgeon and facial cosmetic surgeon at Anajan Hair Transplant Clinic, Mumbai, and BK Skin and Hair Group of Clinics. Now, I cordially invite Dr. Avinash sir to deliver us an interesting session on hair transplant, trichology, cosmetology, and cosmetic surgery. The max facts need of the hour. Thank you.
Hello. Yes, am I sufficiently audible? Okay, thank you. So, respected delegates and dear postgraduates, a very good afternoon to you all. I am privileged to be here in the dais as a guest speaker in the college where I finished my post-graduation just 3 years before. I am very grateful to you, Dr. Raviraj sir, the organizing chairman and my HOD for giving such a wonderful opportunity. Today's lecture is on hair transplant, trichology, cosmetology and cosmetic surgery. Is it a real need of hour for a maxillofacial surgeon? So let's see. Before starting my presentation, I just want to thank all my teachers for their constant support. Dr. Raviraj sir, Dr. Mehboob sir, Dr. AOMSI sir, Dr. Praveen sir, Dr. Srikanth sir, Dr. Hari sir and Dr. Manohar sir. A very thank you to all. So the next half an hour you are going to travel in a new world, is the world of beauty. I welcome you all. So first let's see what is trichology. Okay. Thank you. So let's see what is trichology. So it's nothing but it's a science of hair. What trichologists will do, they study the diseases of human hair and scalp. That's why most of the trichologists call themselves as scalp and hair specialists, but actually it is not. Is it a medical science? No. Trichology is not a medical science, it is a paramedical science. What trichologists usually do is, they'll see the hair loss patient, they will evaluate the reasons for hair loss, they'll take their medical history, they'll send them for blood tests. These are all things they'll do, but they cannot do any treatment or any procedure. They need to refer the patient to a concerned doctor, to the surgeon for the procedures. What is the role of a trichologist? As I said, they evaluate the hair loss. They suggest individualized treatments for the patients, what they need to do. They give some nutritional advices. They advise some lifestyle changes. They are just an assistant to a doctor for the procedure. They cannot do any treatment. When you start your trichology practice, here are some common hair issues which you usually notice in your practice. If at all, if you know, you can guess the conditions. I'll show the picture. This is a male pattern hair loss. It's a genetic hair loss which is usually seen in 70% of your hair practice. Hair transplant surgery is the option for these cases. This is the female pattern hair loss. The picture shows different grades of hair loss in the females. This is telogen effluvium. This is the case which we, right now we are usually noticing in our practice after COVID. After recovering from the COVID, 3 months after the recovery, usually if anybody of you notice the increase in the hair fall, it is telogen effluvium. This is an autoimmune disease. You can see single or multiple patches of hair loss in the scalp, which is alopecia areata male. The same in alopecia areata female. This is alopecia areata beard. These are all autoimmune diseases which you can notice. This is traction alopecia due to prolonged tension on the hair, usually due to ponytails in the girls and turban wearing in the Punjabis. You can see this traction alopecia where there is loss of hair in the frontal area. Here are some common scalp conditions which you notice in your trichology practice. Seborrheic dermatitis, where you can see the white colored flakes in the scalp. And this is scalp psoriasis, where there are thick white scales you can notice on the scalp as well as in any other body part. And this is the tinea capitis, which is a fungal infection which we call ringworm of the scalp. These are some common hair and scalp conditions. I just want to show the different clinical conditions. This is for postgraduates, I feel. So, trichology training in abroad. This is one of the oldest school of trichology. This is in UK, London, established in the year 1902. There are different level of courses. There is a 2.5-year course you can attend. Distance learning is available. You can do it from your home. But for clinical training, you need to attend for London. There is a World Trichology Society in Jacksonville, Florida, USA. Dr. David Kingsley will be your trainer there. There are multiple courses, but you need to attend few days of clinical training. In India, the clinical training is available with this society. The US Trichology Institute, which is a private institute, it is in New York, USA, and they have different level of courses. It's a National Trichology Training Institute. It is in Georgia, USA. It is established in the year 2006. And Dr. Koni is your trichologist here who will train you. This is one of the famous institute, International Association of Trichologists. They have the only university developed trichologist course. They'll give the certificate from South California University. The clinical training is available in different countries. Why this institute is famous? Because the 2 trichologists who are practicing in India, they have done their course from this institute in the past. Coming to the trichology training in India. Probably you might be knowing this Richfield Trichology Center. They started their practice in the year 1986. They have a lot of hair and scalp clinics. Dr. Sonal and Dr. Apurva, they have across almost 100 plus clinics across North India. Interestingly, they both are homeopathy doctors. They got their trichology certification from IIT Australia. The eligibility for a trichology course is a healthcare professional. You must be a healthcare professional, and some of the institutes you should be 18 plus. That's it. So VK Trichology Clinics, you might be knowing her. They have 34 clinics all over South India. Unfortunately, she is a MBA student. She is a business graduate. She has done her trichology course in 1984. Long before the eligibility is just 18 plus. Right now they have changed to healthcare professionals. And she got her certification from IIT Australia. Here are some frequently asked questions from most of the students. Trichologists, are they doctors? The straightforward answer is no. They are paramedics. Can trichologists do hair transplants? Absolutely no. They cannot do a hair transplant procedure. They can help in doing the procedure, but they cannot do hair transplant. Is trichology certification valid in India? Yes, there are. Just now we have seen the Richfield and VCare. It is valid. What is the difference between trichology and dermatology? So trichology is exclusively limited to the hair and scalp. A dermatologist can do a trichology practice, but a trichologist cannot do a dermatology practice. Can trichologists open a clinic? Definitely yes, but it should be a trichology clinic. Why trichology for Max Fact? It's a very vast subject to learn, because if you type the keyword hair in PubMed, you will get almost 1 lakh articles on hair. So it's a very vast subject. Some basic certificates should be needed for maxillofacial surgeons to see the hair and scalp patients, as it was not there in our curriculum. You cannot find the trichology in any of our books. And to avoid certain legal issues, if any of your patient asks how a maxillofacial surgeon you are eligible to do, or you are eligible to see a scalp and hair patient, you need some certificate to support yourself. An international certificate is valid as it worked for both the Richfield and VCare. So you can do an international course in trichology. Since in India, dermats are promoting more as trichologists, that's why people also prefer like they consider trichologists as doctors, but unfortunately no. So even people believe that a trichologist is always a dermatologist. So at least in future we will see the maxillofacial surgeons as into the trichology practice, so that people will believe that we also do trichology. So we need some certificate to support and promote ourselves as trichologists, at least now. Let's go into the second topic, the hair transplantation, which is a hot topic among all the doctors as well as the patients. Probably you might be knowing this person, the owner of Lalita Jewelry. He usually wear this style, the full bald style. So one of the interviewer asked me a question, "Sir, why you are always in this style?" So he just said, like every day he is wasting half an hour to 45 minutes just seeing in the mirror that I don't have hair here, I don't have hair here. So just to avoid that wastage of time, he just shaved his head. For every 4 to 5 days, he used to shave his head. So probably he might not be knowing about hair transplantation at that time. So basically, what is hair transplant? You just transplant the hair from one place to the other place. That's it, simply. We take the hair from different sites. Here in the picture, you see the safe donor area. This is the place from where we extract the hair grafts. This is considered as a safe donor area where we can remove the hair grafts which we can use for hair transplantation. There are different techniques, follicular unit extraction and follicular unit transplantation. Both the techniques differ in the way how we extract the hair grafts, but both were similar in the way how we implant the hair grafts into the bald area. Here you can see the picture. This is after healing. You can see a scar in the back. This is an FUT method where we remove a strip of scar from the donor area. Here this is FUE where we use the different punches to extract each individual hair follicle. I'll just show you how. This is follicular unit extraction procedure. I'll just tell you how we do. So whenever a patient comes to your clinic, first we will mark the bald area, then we shave off his head, then we give local anesthesia in the back from where we extract the grafts. Then we use the micromotor and a mini punch to extract each individual hair follicle. After extraction is done, we transfer all these hair grafts to a storage medium, usually chilled normal saline. So after that, we use these grafts and we implant in the area where there is deficient hair. This is how we do follicular unit extraction procedure. And follicular unit transplant, this picture shows after the healing, you can see a line of scar. In this technique, we remove a strip of scar from the donor area and we sliver the strip into individual skin grafts and then we use these hair grafts for implantation. This is how FUT we will do. There are different types of hair transplant. Scalp hair transplant male, you all know this. Luckily, most of the females now they are getting more towards the transplant surgeries. So beard transplant, we can use the scalp hair for beard transplant or we can use the chest hair. Sometimes we have to do pubic hair too. So mustache transplant, even for some of the cleft cases, we can do the mustache transplant in the area of the scar. This is eyebrow transplant where there may be deficient eyebrows or missing eyebrows genetically, we can do eyebrow transplant for them. Coming to the training part, this is the International Society of Hair Restoration Surgery, like how we have IAOMS, this is for hair restoration surgery, ISHRS, but unfortunately, they are not accepting us for the membership. They have their minimal qualification, MBBS, so we are not eligible for their membership. I requested the secretary, they are telling various reasons. So far we are not eligible. And Association of Hair Restoration Surgeons of India, this is AHRS, like how we have AOMSI. This body, mostly they are plastic surgeons. Even before they used to give membership for us, but even they removed the criteria, we are not eligible for the membership. It's a private institute, Ilamed Institute of Laser and Aesthetic Medicine, Dr. Rana. He's a dermatologist. He will be our trainer. The institute is in Mumbai. ISHR, Indian Society for Hair Restoration, Mumbai. Before it was good, but right now it was not that good. It's a Jayanti Ravindran, a cosmetic surgeon in Chennai. She used to conduct different courses. You can go to her. Dr. Pradeep Shetty, a renowned dermatologist from AIMS. So he has a fellowship course in D.Y. Patil University, Mumbai, for which we are not eligible right now. So Dr. Arun Panda, you might be knowing her. He's a renowned maxillofacial surgeon. He's practicing cosmetic surgery since 10 years in Mumbai. You can go to him. He has a 3-day workshop in hair transplant. Dr. Bhavesh Gupta, another maxillofacial surgeon. He used to conduct a workshop for 2 days in hair transplant in Mumbai. And is Dr. Tejinder Bhatti, a renowned plastic surgeon from Mohali. He used to train he has an acceptance of us. You can go to him and learn hair transplant. AK Clinics, Dr. Aman and Dr. Kapil Dua, both are dermatologists. They give training for various departments, but not for us. And abroad, you can go to Turkey, Natural Hair Transplant Academy, or you can go to American Board of Hair Restoration Surgery, the only board certified hair restoration certificate, and ISHRS. Here comes the hot question, is maxillofacial surgeon eligible to do a hair transplant? This is the latest updated curriculum of MDS maxillofacial surgery. Here in the curriculum, you can see the word tissue grafting. As hair transplant surgery is considered a tissue grafting procedure, we are not just plucking hair and transplanting them, it's the skin graft we are doing, it's considered as a micrograft. So it is considered to be a skin graft. This is the only line in the curriculum which supports a maxillofacial surgeon for doing a hair transplant when you go for legal issues. Like, it should be in the curriculum, it should not be in other websites. It won't work out when something happens wrong. And aesthetic facial surgery, it will come later for cosmetic surgery. And this is the list of procedures in our curriculum, what we need to do in our post-graduation period. In the 18th column, there is a skin graft column. Here you can see PI and A. PI is performed independently and A is assisted. So in your post-graduation period, you need to perform independently 2 skin graft cases in your curriculum. So with this support, we can do a hair transplant procedure. This is what we can support ourselves for doing a hair transplant. Even in National AOMSI website, they have included the hair transplant word in the column of cosmetic surgery, which is very good for us. If any common people, if you ask, if they ask you, can you do a hair transplant, you can just tell them to search maxillofacial surgery in Wikipedia. That itself says that you are eligible to do a hair transplantation. This is just for the common people. Who are all doing hair transplant surgeries outside? The plastic surgeons who are absolutely eligible to do a hair transplant surgery. Dermatologists, even though it is a medical specialty, they are naming themselves as dermatosurgeons and they are doing hair transplants. ENT surgeons, in the name of facial plastic surgery, since they are limited to head and neck, they are doing hair transplant surgeries. I don't know how they are eligible. Some of the ophthalmologists are doing in the name of oculoplastic surgery. This is all happening because of lack of strict regulations. Not only in India, throughout the world, there are no strict regulations for hair transplant, who need to do, who not to do. But you should be very cautious. This is the dermatology curriculum. You can see the entire dermatology curriculum from the National Medical Council, National Medical Commission. There is no word of hair transplant anywhere in their curriculum. They are eligible to do minimally invasive procedures, but not hair transplant. What are the pros and what are the cons of a hair transplant? Revenue. Definitely revenue is a pro. You can earn good revenue, but at the same time, revenue is a con. Why? Because usually hair transplant surgery will take around 6 to 8 hours per single day. Usually most of the patients need 2 to 3 day surgery. It will go to 16 to 24-hour surgery for a single patient. In the same time, you can generate more revenue with other maxillofacial procedures. That is why it is a con. It's a procedure in demand because hair loss is a common condition nowadays. So definitely it's a procedure in demand. It's an add-on practice, like add-on procedure for your regular maxillofacial practice. Coming to the cons, as I said, revenue is one of the cons. Specialty practice is needed. If you practice regular dentistry, patients are not at all eligible, they are not willing to come to your clinic if you practice regular dentistry. So you need to focus on specialty practice. Competition from the other departments. Legal issues regarding eligibility, as I said, whenever something goes wrong, it is the curriculum, it is going to support you. So that is why I requested Dr. Preetham sir and Dr. Veerbahu sir to kindly update the next curriculum, kindly introduce the word of hair transplant into the curriculum. Duration of the surgery is a con. Usually hair transplant surgery is a very safe procedure, but there are certain chances of death. Here are the cases which are reported all over India. The first case recently, 1 week before, it was reported in Gujarat. A 31-year-old died after 3 days of hair transplant surgery. A Mumbai man dies after 9 months of hair transplant. This is a Chennai hair transplant death case. An MBBS student who got the hair transplant, he died 3 days after the surgery. And this is in Hyderabad. The patient lost his eye after hair transplant surgery due to necrotizing fasciitis. It damaged his optic nerve and his eye has to be removed. So usually safe, but there is risk of death in hair transplant surgery. And we are lucky. Why? Because all these cases happened in the hand of dermatologists. If any one death case happen in the hands of a dentist or a maxillofacial surgeon, I feel that will be the end of hair transplant for us. Since till now it was not there in our curriculum, you need to be very careful. If something goes wrong, then all these legal issues will come into play. So please be cautious. Coming to the third topic, cosmetology. So what is cosmetology? Is nothing but the study and application of beauty treatment. Again, is it a medical science? The answer is both yes and no. There is something called medical cosmetology and a general cosmetology. So this is the difference between a beautician and a cosmetologist. A beautician do all these procedures, hair care, hair cutting, hair styling and all. Cosmetologists usually do more procedures than these. All cosmetologists are considered as beauticians, but all beauticians are not cosmetologists. This is regarding general cosmetology, which you see outside in the spas and wellness centers. There are different workplaces for cosmetologists, cosmetology schools, spas and wellness centers, beauty parlors, skin clinics, cosmetic companies, film and fashion industries, independent cosmetologists. So there are different list of procedures, skin care, bleaching, this is all general cosmetology. You can see the Anu's International Beauty School, which have the advanced diploma in cosmetology too. Again, can a Max Fact practice cosmetology? So this is a news published in 2016. The 10 doctors face rap for practicing cosmetology and diabetology. This is in Chennai, the Chennai Medical Council. What they said, like the Chennai-based MBBS graduate for offering cosmetic treatment after a 6-month course in Singapore. So what the Council of Chennai said that a doctor should have a postgraduate degree in dermatology or plastic surgery to practice cosmetology. And if you see the Clinical Establishment Act, in the dermatology, this is for dermatology clinic, you can see in the last column what they have written. Dermatologists providing cosmetology services must have a certificate from government recognized centers to practice cosmetology. This is from the latest Clinical Establishment Act for a dermatologist. So even they are not eligible to practice regular cosmetology without a proper certification. This is what, if any of the doctor, you need to keep a cosmetology certificate in your board, you need to do medical cosmetology, it's not general cosmetology. Then what is medical cosmetology? It's a combination of medical science and aesthetic beauty treatments. Usually in other countries, healthcare professionals are eligible to do this. And this is in AOMSA website, cosmetic surgery curriculum, where they have introduced the cosmetic procedures list. Here are some common procedures done by a medical cosmetologist. The Botox injections for different frown lines and forehead lines we can do. I'll just go through the list of the procedures. It's a chemical peel which used to do for skin resurfacing or acne scars or pimples, or this is a case of active pimples. They have done a salicylic acid peel for them, which is antibacterial peel. Dermal fillers for the last volume of the temples or for the last volume of the cheeks or to plump up your lips, you can go for a dermal filler. Laser resurfacing, again for skin toning. Dermabrasion, again for skin resurfacing. Face mesotherapy for skin rejuvenation. RF skin tightening, whenever you have a sagging cheeks or sagging jowls, you can go for skin tightening, which is an alternative to facelift procedures. It's a vampire facial where you combine microneedling with platelet-rich plasma injection over the face for skin rejuvenation or for acne scars. So molar water removal, we can do it with electrocautery. Coming to the training part, there are different programs all over India and all over the world. Fellowship in cosmetology, all these names, it's a similar kind of program with different names. Ilamed, as I said, Dr. Jemina Pai, she is a renowned dermatologist in Mumbai. She is giving different courses for cosmetology. You can go to her. She is a celebrity skin expert, and since 2 decades she is for Miss India competition. You can go to her. And there is a university fellowship in Mumbai under the dermatologist Dr. Srilata in D.Y. Patil University and Dr. Arun Panda workshop. Dr. Sapna Vedera, she has a cosmetic synergy program for 2 days workshop in Mumbai. And Dr. Debra Shum, an ophthalmologist and specialized in facial plastic surgery, he has a course in Mumbai. You can attend to him. And let's come to the final topic, cosmetic surgery. So what is cosmetic surgery? Any surgical procedure to enhance the patient's appeal. So what is the difference between plastic surgery and cosmetic surgery? So usually plastic surgery is just the difference in the terminologies. Plastic surgery usually involves the reconstruction. Cosmetic surgery is done to enhance the appearance of the patient. As you know, general plastic surgeon, he deals with the entire human body. We, the facial plastic surgeons, are limited to the face or head and neck. Different surgical procedures done by a cosmetic surgeon. The eyebrow lift or the forehead lift done for the wrinkles on the forehead, or you can do for the frown lines. The buccal fat removal, you can do intraorally to remove the excess fat for improving the cheek contour. You can do the cheek augmentation with the help of different silicone implants, or you can use the bone material. And the genioplasty, you all know. The otoplasty is a cosmetic surgery of the ear with which you can change the shape of the nose shape of the ear, or the position of the ear, or the size of the ear can be done. So blepharoplasty is a correction of the lower eyelid, the sagging lower eyelids, the eyelid bags. All these can be corrected with blepharoplasty. You can remove the fat from the lower eyelid. It's a facelift or rhytidectomy, which we do. The sagging jowls or the sagging skin over the cheeks can be corrected with the facelift. This is a thread lift. It's a non-surgical facelift. We can use different silicone threads or the absorbable PDO threads to lift your skin if it is sagging. So rhinoplasty, you all know, it's a cosmetic surgery of the nose to correct the shape of the nose. Coming to the training part, A renowned facial plastic surgeon, Dr. Nabil Faki, Lebanon, he has different courses. If you really want to learn facial plastic surgery, you have to go to him. This is in the Middle East. He used to train, he has different courses. And he is one of the vice president of Spanish Society of Facial Plastic Surgery too. You can attend him. He is one of the renowned cosmetic facial surgeon in USA. He has a very good book on cosmetic facial surgery. You need to read the book if you want to learn cosmetic facial surgery. Recently, last week, they have finished almost 1,400 facelifts so far in the span of 10 years. A very good number of facelifts they are doing. And this is from India. He is Dr. Mohan Thomas, facial plastic surgeon. He is a plastic surgeon. He has a fellowship in Mumbai. Maxillofacial surgeons are eligible to do this fellowship, but this is a 1-year course and you have to pay 10 lakhs for the course. Dr. Brajendra Basar, he is an ENT surgeon, a renowned ENT surgeon, and he has done almost around 10,000 rhinoplasties so far. If you want to learn rhinoplasty, go to him. Dr. Jayanti Ravindran, again, she is a cosmetic surgeon in Chennai. He is one of the emerging maxillofacial surgeons who is conducting rhinoplasty workshops in Guwahati. Again, is MaxPack eligible to do facial cosmetic surgery? Absolutely yes. This is the curriculum. In the aesthetic facial surgery has been in our curriculum, so you are directly eligible to do facial cosmetic surgery procedures. Again, in AOMSI website, you can see the column. So let's see what are the problems we are facing today. Need of update in our curriculum. Sincerely from our side, we request the AOMSI body to kindly update the curriculum. Competition, legal issues again, loss of patient's trust if you practice regular dentistry. Dermats or plastics are against us for sure. If you go to Hyderabad, every day there is a discussion in the dermatology WhatsApp group that maxillofacial surgeons are doing hair transplant, they are doing some cosmetic procedures. They might not be knowing fully about us. Lack of sufficient knowledge on all these topics for us. So what we need to do? Try to focus on specialty practice. Try to promote yourself as a facial plastic surgeon or facial cosmetic surgeon or head and neck surgeon rather than an oral and maxillofacial surgeon. There is an article published by Dr. Thangavelu sir long before. I have seen few days back that we need to change the department, like our field, the name of field, like it has to be a cosmetic surgery rather than oral and maxillofacial surgery. This is for postgraduates. Utilize your postgraduate period as much as you can learn. Try assisting, try observing different types of cases in your postgraduation period. Try to start cosmetic surgery in college as a thesis, as how we have done hair transplant surgery thesis in our college under Dr. Mehboob sir. Thank you for that, sir. Start writing articles on cosmetic procedures. And at college level, try to associate with a dermatologist or a plastic surgeon and do the procedure so that at least they will know who we are. And my final word to the budding surgeons. So, I want to be the greatest surgeon. This is what a postgraduate will feel when they enter into the Department of Maxillofacial Surgery in their first year. But at the end of post-graduation, they feel like at least I should pass out as a surgeon, forget about the greatest surgeon. And when you enter the clinical practice, you feel at least people should recognize me as a surgeon but not a regular dentist. This is how life goes on. So trust me, stick to this word, at least you will be a very good surgeon at the end. So this is the statement I want everybody to read. Unlike in our times, medical students of today do not spend much time with the patients and they lack dedication. So this is the word which you might be heard from your professors. Am I true? Postgraduates, please. Am I true? This is the word you heard from your professors, right? So I feel even your professors might have heard from their professors too. So do you know who made this statement? Hippocrates in the year 460 BC said that students are not serious, they lack dedication, they are not taking care of the patients. So I say if any of your professor says that you are useless, don't take that serious. Keep working on it. I want to ask everybody, who is the safest surgeon on the earth? So safest surgeon is the one who does not operate. If you do not take risk, and whenever a complicated case comes to your clinic, if you do not accept and you want to be safe, you will be the safest surgeon, but you will not be the best surgeon. Try accepting the risks, but it should be always a calculated risk. Just watch other surgeons operating. Either you can learn from them, or you can learn how not to operate or how to operate. I have seen some of the surgeons doing, after that, the end of surgery, it looks like a leftover dog's dinner. Just keep exploring within the horizon as well as beyond the horizon, be it a cosmetic surgery, be it a hair transplant surgery, be it a orthognathic, oncology, cleft, whatever it may be, whatever you dreamt of, keep working for it and never, never, never give up on your dreams. Thank you so much.
Thanks a lot for the session, Dr. Avinash Reddy, sir. That concludes our scientific session. Thank you all for your patient listening. Now, vote of thanks will be delivered by Dr. Raviraj, sir.
Good evening, everybody. I think the theme of the conference, once it is thought, I think we did justice by selecting the speakers as well as the topic for the lecture, starting from the first topic, microvascular surgery, the need of the hour, and the present scenario, you have to rehabilitate the resected maxilla and mandible only with the microvascular reconstruction to have a form and function. The second topic is on cleft and craniofacial, which is done by Dr. Srikanth and Gosla sir. And then the oration, it is a general topic because we knew Dr. Tanga sir will take the students into his world and he'll explain whatever way he can. That's why the concept is changes and challenges in wound maxillofacial surgery. And coming to the pterygoid implants by Dr. Leela Krishna, the topic that is chosen because these days the routine endosseous implants are practiced by all the departments, and in fact a well-trained BDS person is also confidently placing dental implants. But when it comes to the atrophic ridges, whether it is the maxilla or mandible, the choice of surgical procedure that is done by a maxillofacial surgeon is definitely a cut above or a level above compared to the other practitioners who does the routine dental implants. Say for example, zygomatic implants, it can be handled. I won't say we are the authenticated persons. There are few persons who are mastered with their own interest and all, but when it comes to the atrophic ridges, the choices being a zygomatic implant or a pterygoid implant. So in such scenario, a maxillofacial surgeon needs to be he plays an important role for the successful placement of implants. And finally, of late I have seen so many of your postgraduates for the past 3 to 4 years, starting from Avinash Reddy, each at least one person from each batch is going towards the cosmetology and hair transplantation. Maybe it is due to the competition, or once they come out, they have a special interest in the cosmetology and the hair transplantation. That's how they went and did the fellowships. And to my knowledge, everybody is doing good in the respective additional qualification what they achieved after the MDS course. So with these topics that is kept for this conference as explore beyond the horizon, we hope we fulfilled. And from the organizing committee, I would like to thank the registrations made towards the delegates and the postgraduate physical attendance. We didn't expect this many registrations, frankly speaking. I thought it will be somewhere around 80 initially. Later, it turned to be, except for St. Joseph Dental College, few PGs were invited from the other departments like pedo, prosthetics, ortho and perio departments because some relevant topics are there for them. Almost 130 registrations of physical attendance from both the delegates and the postgraduates happened. In online we have enough number because a postgraduate need to submit the certificate, or he should have a certificate in this pandemic situation. What else simple to have, just register, submit the paper and take one certificate. That's how I had a lot of confidence that online registrations will go more. I had a hesitation that I might touch 100 registrations, but it's crossed, and with all the best wishes of the seniors and other faculty members and the maxillofacial fraternity in and around Andhra supported, and we have papers coming from other states, non-AP state. That's made me to categorize the papers, prize papers again as AP and non-AP, not to lose our students, the postgraduate students from our state. The prizes will be equally delivered for both AP state and non-AP state categories because of the good response from the postgraduates in the prize and poster category. I have taken judgment like that. And finally, I would like to thank the management, principal, and the department faculty for giving me the support and living up to the expectations of the delegates and the registrants. Last but not the least, the department staff, nurses, ayas, and the auditorium staff, starting from the electrician, our OT staff, Mr. Nani, and all the persons who are involved in this scientific, to make this scientific session more successful with a short notice. If any shortfalls, I apologize from the organizing committee, being the organizing chairman, and I hope we lived up to their expectations, and that's how I conclude the valedictory function by offering a big thank you for all the delegates who have come from all the parts of the Andhra Pradesh and for the good support. Thank you. Shall we all rise up for the national anthem? Thank you. This concludes the scientific session, and I request all the participants to have the refreshments near the auditorium, and members of the AP State AOMSI, I request there is all of them to gather near the lecture gallery